All right. A day in the life of a clinical documentation specialist. Our disclaimers: this material is designed and provided to communicate information about clinical documentation, coding, and compliance within an educational setting. The presenter is not providing or offering legal advice, but rather practical and useful information and tools to achieve compliant results in the area of clinical documentation, data quality, and coding. Every reasonable effort has been taken to ensure that the educational information provided is accurate and useful, and applying best practice solutions and achieving results will vary in each hospital or facility and/or clinical situation. So our goals and objectives today, we're going to understand the CDI role and functions within the inpatient setting. We're going to learn how to perform initial and subsequent chart reviews by applying the general coding guidelines. We're going to review and create queries for diagnosis specificity, perform DRG validations between the discrepancies of the final coding and CDI final DRG assignment, and understand and create CDI program metrics for financial and quality impacts. So what is CDI? What is clinical documentation integrity? It's a bridge. It's a gap. It bridges the gap between the clinical information and the coding rules, right? So we're a team of dedicated healthcare professionals, and we assist the medical staff to document diagnosis specificity relating to severity of illness and risk of mortality data scores for all the patients within the hospital setting. Now, just keep in mind, we are discussing inpatient. I know outpatient CDI has been blossoming and going off the charts now, but we are just focusing on inpatient. So the CDI team, as you can see, it takes a village to have everybody participate in CDI. So of course you have the CDI specialists, you have your physicians, nurse practitioners, your physician assistants, residents, you even have any fellows that may be involved if you're in a university teaching facility, hospital. Case management is also a big thing to get involved with when it comes to getting clinical documentation, especially for your general mean length of stay. That's what case management is looking at, and medical necessity for that patient to be in the hospital. Of course, all our HIM professionals and our coders. Quality management is a big piece because of the value-based purchasing programs that are out there today with your patient safety indicators. And then, of course, your executive administration. If you don't have buy-in with your executive administration or your senior leadership, your CDI program may not survive. So the key functions that we look at is to accurately reflect the patient's severity of illness, or SOI, and risk of mortality, ROM scores, through provider documentation based upon diagnosis specificity of all the patient's comorbidities. So it's not just what bought the bed for that patient, what's the acute condition, but also making sure that all the comorbidities, chronic conditions these patients have coming in the hospital are specified to the nth degree. What I tell all the docs when I worked with them in the hospital setting, tell us the story of the patient's journey from admission to discharge within the medical record. In other words, put down all your thoughts with what you're doing, what you're trying to figure out what's wrong with that patient. If a patient comes in with a sign and symptom code like syncope, they're going to work them up. They're going to do cardiac workup. They're going to do a brain scan, this and that. So we want to see what they're trying to do. What are they trying to rule out on this patient? Is it a cardiac etiology? Is it a CNS? Or neurologic etiology. So it's really important that they put their thoughts in their documentation. All right, CDI reviews. So initial reviews, they start to tell you the story, right? The patient's admitted to the hospital. We want to see, okay, why are they admitted? What bought the bed? And then we're going to figure out from there, the docs are going to figure out what's going on with that patient. Now, your subsequent reviews update the patient story of the hospital admission. So this is where your query opportunities may be found in your subsequent documentations. Usually, your query processes are utilized for inconsistent, vague diagnoses that require further specificity. Like everything that comes to mind is they write heart failure. They give you the type, but they don't give you the acuity or the severity. They'll write diastolic heart failure, but they don't tell you if it's acute, chronic, or acute on chronic. Subsequent reviews, most of your subsequent reviews that in the years I've been a clinical documentation specialist, is where you find your query opportunities. Now, however, if you're reviewing an initial review, a record that's the patient's been in the hospital for 4 or 5 days, you may still have opportunity there because you have a lot more reviews, a lot more documentation to review. But 9 times out of 10, your subsequent reviews are where you're going to find your query opportunities. So let's go through the initial review process. So when you're with your initial review, the emergency room summary, if they came through the ER, and inclusive if they were brought in by EMS, paramedic squad, you're going to look at all your admit orders, inclusive of all your medications that were ordered, and of course the H&P and any consults that were called in for that patient, as well as the diagnostic testing and lab results. This is the most important review for your CDI as a CDI specialist because you want to build the story of the inpatient admission. I think it's very important to make sure that you capture everything what's down there within the record on your first review. And this is where you have your potential, opportunities to think about when you're reviewing that record for that patient. Now, your subsequent reviews, these are all additional progress notes, any additional diagnostic testing, lab results, and any consultants that might have been brought in on the case during the stay. So like I said, as a CDI specialist, your potential queries are found in your subsequent review process. It's really important that you get your initial review. Your initial review with your working DRG assignment or your principal diagnosis, your PDX, primary diagnosis, is going to change throughout the stay because you're doing concurrent reviews. So even though a patient came in with syncope, they found out that the patient may have complete heart block, that's going to be your ultimate primary diagnosis. And then they end up going for a pacemaker procedure. Okay. So this is why you always want to look at it. I know a lot of the facilities where the current facility I review for as a contractor, we look at our initial reviews 24 to 48 hours. And then subsequents are also 24 to 48 or sometimes 72, depending on how, if we maxed out that DRG assignment with the SOI of 4 or the ROM of 4. All right. Any questions thus far? It's pretty straightforward. All right. Okay. Queries. Let's talk about queries. This is what most of all the CDI programs are about, is querying providers. So what is a query? Well, it's a communication tool that is used by the CDSs to clarify inconsistent, conflicting, and vague diagnoses. The goal of the query is to improve diagnosis specificity in order to accurately reflect the SOI, severity of illness, and ROM, risk of mortality, ultimately achieving the highest level of quality care for each patient. So when you have diagnosis specificity overall for all the diagnoses that are documented within that hospital record, that assist all the providers in promoting high quality care for that patient. So reasons, why do we query? Well, clinical indicators for a diagnosis that is not documented in the patient records. So we have clinical indicators for, say, dehydration, but the doctor didn't specify the diagnosis of dehydration. So that's what you're going to query A cause and effect relationship between two conditions. How about an underlying cause when a patient is admitted with a symptom, like I said about the syncope example? And then present on admission status is really important when it comes to coding, because there are certain things that we look at, and the biggest thing that we look at are the HACs, the hospital acquired conditions. So that's why we always want to clarify POA status for all the diagnoses within that record, especially if they're on the HAC list. So what is CMS? CMS is the Center for Medicare Medicaid Services, and their position on queries, they stated, quoted here, "We do not believe there is anything inappropriate, unethical, or otherwise wrong with hospitals taking full advantage of coding opportunities to maximize Medicare payment that is supported by documentation in the medical record." And they further stated, "We encourage hospitals to engage in complete and accurate coding." This was back in 2008 that CMS made that statement. And they still stand by their statements today. Now, there was a update with the compliant query guidelines, and AHIMA and ACTIS got together last year in 2022, and they created the compliant query guidelines together. And you all know they merged, right? ACTIS is now merged with AHIMA. Y'all hear that, right?
I didn't know that.
Yeah, they merged just this year, 2023. So they're working together, but I think that whatever certifications you have, whether it's AHIMA or ACTIS, you still go according to their recertification processes. Okay, it's not changing. Just an FYI.
A
Okay.
question, Mary.
Yeah.
Yeah. So I haven't take any exam, but I'm trying to do a HEMA. So are there going to be
Right.
like different exams that they're going to do, or it's going to be the same? Like if I'm got certified with a HEMA, it's ACTIS will accept it, something like that.
Well, depends on what. Well, if you're going, Roy, if you're going for the CDIP, the Clinical Documentation Improvement Practitioner, or HEMA offers. Yeah, so you're going to go according to what their guidelines are. You know, for once you get your certification and then their recertification. ACTIS has the certified clinical documentation specialist certification. So the CCDS.
So
they're keeping, so if you go for a CCDS with ACTIS, you go according to what their recertification process is. So they're still separate, even though the organizations merged. Their different certification guidelines are based on what they have in place already. So a HEMA for CDIP, you go according to what they have, their guidelines for research. So if you have a CCDS, you go according to what ACTIS guidelines are for recertification.
Okay. All right. Got it.
Okay.
Thank you.
You're welcome.
Yeah, because we don't know in the long run, because it's just a new merge company. So probably they try to merge what their requirements for being a certified clinical documentation specialist. So, but I think for now it's still the separate test. It's different type of test that they provide, but either certification is accepted in a hospital or outpatient setting. So, because most of the time they'll say CDIP, what do you call this, required, or CCDS required. So those are the two certification that's needed when you apply for a job. But sometimes they also have, I think, I forgot, there's another hospital that when you apply, they don't need the certification, but you need to get it within 1 year of your hiring. So, but these are just the two certifications that are required when you practice as a CCDS.
Okay. All right. Thank you.
Yeah, you're welcome. So with the compliant query guidelines now, this is what AHIMA and ACTIS said. Be compliant with the practices outlined in this brief, right? So you want to go according to what their guidelines are. You don't want to develop any problems for the hospital when you're sending out queries. You want to be clear and concise with each query you write. You want to apply the clinical indicators from the health record within the query, and you use quotations if directly quoting the provider's documentation. All your multiple choice query options should only include clinically relevant options and exclude clinically irrelevant options. For example, if you have a sodium level of 122 and a query is sent to determine the diagnosis can be, if a diagnosis can be provided, hypernatremia would not be an appropriate answer option within your query. So you only want clinically relevant options within all queries now. In addition to the choice of other, there is no mandatory maximum or minimum number of diagnosis procedure answer options. So you can put how many answer options you want, how many choices you want within that query. Sometimes you just have, usually you could have 2 or you could have 3 only. Okay. So you just want to make sure it's clinically relevant to the query, the question you're asking the doc for further specificity or a specific diagnosis in that query. And multiple choice answer options are to include the answer option of other to allow the provider to customize their own response to the query. So, they're the head honcho, the attending provider. He's the captain of the ship, so to speak, right? So you want to make sure that it's clarified that if he doesn't like the choices that you may have given him, he's like, no, it's something different. Then he can write out exactly what he thinks it is on that query response form. Answer options that may be used but are not limited, but are not required include unknown, unable to determine, not clinically significant, integral to, unable to rule out, inherent to, or other similar wording. I know a lot of the, when I'm sending a complication query to the provider, to the surgeon, if it's a complication that developed related to the procedure, I like that integral to verbiage because that goes a long way. Or, or inherent to. Because I think it helps the docs. You don't want to ding the surgeons if you're writing. I know I just sent a query for post-op respiratory failure, and the intensivist wrote it, and I was like, "What is he doing?" I said, "I don't think it's related to the procedure. I think it's because of his lung disease the patient has." So I said to just him to clarify, as a post-op complication or not. So of course, I'm still waiting for the answer from the intensivist because, when they write post-procedure or post-op, they're dinging the surgeon from a quality standpoint. So you really don't want the surgeons to have problems down the road when it comes to quality care, right? Because that's part of the patient safety indicators too on the outpatient side that they're going to be reviewing those records. Any insurance company, mainly Medicare and Medi-Cal, right? Okay, the other compliant guidelines here, unable to determine or clinically undetermined, must be included with all POA query options. So you do not have to add in unable to determine, clinically undetermined into all your query choices now, but they have to be included within your present on admission query option. And you only present the objective data from the health record, identifying why the query is, why the clarification is required. Why are we sending it? You want the objective data to, the clinical indicators are your objective data or your clinical evidence within the record to support a specific diagnosis, right? For example, if you need a type of heart failure, you want to make sure you have the echo, right? Based with the EF, so the doctor can make a decision on what type of heart failure it is. If you don't have an echo, you're going to be hard pressed to get that type of heart failure diagnosis. So it goes on when to query. So our guidelines, when to query, to support documentation of medical diagnosis or conditions that are clinically evident, to determine if a diagnosis is ruled in or ruled out. That's a big piece of the pie that I like sending, especially when they're 4 days into the hospital stay and they're saying all of a sudden they're writing that the patient is suspected with sepsis due to pneumonia or whatever. And then all of a sudden on day 3, that sepsis diagnosis is dropped off the record. No more documentation of sepsis. So you want to confirm that, okay, did they rule it out then? You know, they didn't say that it was ruled out or it's less likely. So we have no idea. So as a CDS, you want to clarify that sepsis diagnosis because that's one of the big heavy hitters I call one of the red flag diagnoses you want to clarify. You also want to clarify the objective and or extent of a procedure. Now as CDSs, we leave the coding for procedures to the coders, right? We have to, what we look at, Christy, what were we mentioning? The one piece of the procedure documentation we look for is the, was it the root?
Incisional.
Yeah, the root operation character.
Yeah, the root
I think it was
operation.
the root
Yes.
operation, right? So
Uh-huh.
as a CDS, you really want to focus on the root operation, like excisional or non-excisional, when you're coding a procedure. The coders, they're good at that. They know how to handle all those procedure codings. So definitely we want to help them to make sure that the extent of the procedure and if that root operation is not correct, or maybe it's should be an excisional instead of a non-excisional. This is where we help them, the coders, with getting that information within the record by the surgeon. So you would, of course, query the surgeon on that. You want to clarify the presence or absence of a complication. I've just mentioned that, an example of that. Clarify a diagnosis on an ancillary note that has been signed by a provider. So usually we have currently an example of that would be the pressure injuries. Your wound care team or the nurses within the organization I'm currently working for, they document all their, the stages, right? We ask the providers, don't document the stage. Please leave it up to the wound care nurses to do that. But we need the site and type listed by the provider in order for the coders to pick it up at the final coding. So my prior job at Henry Mayo, we created a template for the wound care nurses, similar to having online queries that the provider can sign right off on that template for the pressure injuries or ulcers. So it's part of the medical record, and it definitely helps because that way the doc has it in there, and then they can just write in what the wound care nurse wrote right in their progress note or in the discharge summary, so it's captured by the end at the end of the stay. We also want to send queries for present on admission status. Present on admission indicator assignment is really important when it comes to your hospital acquired conditions, your HACs. Like the biggest ones, your stage 3 and stage 4 pressure injuries are a big one that come to mind all the time, because I think it's important to let them know, that's part of the hospital acquired. We didn't cause that. They came in the door with that, especially your elderly adults who are at nursing facilities. They stay there. They're permanent residential care facilities. You also want to establish the relevance of a condition documented as a history of to determine if that condition is active. Say they have a history of AFib. Okay. Well, are they still getting Plavix? Are they getting any type of anticoagulation? Are they getting something else done? Maybe they just have a history of, they no longer have AFib. So that's something that you definitely want to look at. Another history of, if they have DVTs, they have a history of DVT, but they're still on anticoagulation. They're going to be on anticoagulation lifetime. So is that a chronic condition then for that patient? You also want to establish clinically supported acuity or specificity of a documented diagnosis to avoid reporting a default unspecified code. And that's like heart failure. You need the type and the acuity of the heart failure, because if you only have the type but not the acuity, it'll go to a CC, but it's an unspecified CC code. If you only have heart failure documented without the acuity and the type, then it's going to be heart failure unspecified. You always want to try to get the unspecified codes specified to as much as possible. You also want to send a query for a cause and effect relationship between medical conditions. You also want to confirm a diagnosis documented by an independent licensed practitioner who does not meet the definition of a provider. Mainly, we're looking at your imaging, your diagnostic testing. You know, the radiologist who reviewed a record, you know, he reviewed a X-ray or a CAT scan. He's an indirect care provider. So he's not part of that patient's care record within the hospital setting. So you always want to clarify with the provider, the attending provider mainly, or somebody, a doctor who is providing care for that patient in the hospital, to confirm if that's an appropriate diagnosis that should be confirmed as, you know, clinically significant or not. So that's why it's really important that when you do query, especially path reports are the biggest things that I send all the time, because usually your path report isn't up, you don't see the final path until most of the time the patient is discharged from the hospital. So you definitely want to confirm that with the attending provider. You also want a clinically validated diagnosis that is not supported within the medical record. And I think that's really a big piece. A lot of providers say you're challenging my diagnosis. And I remember telling the docs I worked with at Henry Mayo, I was like, no, I'm not challenging. We just want you to take a look at it to see, you know, is it truly pertinent and relevant for this patient's inpatient stay. We just want you, one of my colleagues, my former colleague says, we want you to take a second look at that diagnosis that you wrote. That's all we're asking. You know, and when you do clinically validate something, I think it's important that you just give them the options. It's like, okay, what is, you know, it is ruled in or whatever, and they add additional clinical evidence in the record to support that diagnosis. And that's what you want to do. You want to clarify the reason for inpatient or outpatient encounters. And you want to resolve conflicting diagnosis or procedural documentation between providers. So when not to query? Well, queries are not needed for every discrepancy or documentation issue, you know, based on your hospital or organization's policy and procedure. And I'm going to tell you, with the company I work for, we query everything. Every little thing we query with this organization I work with as a contractor. Now, circumstances may include lack of, you know, business need, risk of query fatigue, and it does not add to the clarity of the clinical picture. So there are certain times that you may not send a query, you know, even though, say, the patient's really sick with septic shock, came in the door, and you're at a SOI of 4, your ROM of 4. You have numerous, you have like 7 MCCs and 8 or 9 CCs on the case. Are you going to send a query for hyponatremia? Maybe not. However, the current organization I work with, I would send it for hyponatremia, even though you're maxed out with that DRG assignment. Okay, and you do not query if the provider cannot offer clarification based on the present healthcare record documentation. Code accuracy is not the same as code specificity, so keep that in mind. And queries should only be generated when the clinical data, present and relative history data, fully supports the answer choices.
Going back to what Anne-Marie was saying about that you should not query for everything. In that way, for example, like Anne-Marie said, is that a case has already 4 SOI and 4 ROM, or it has already several MCCs, because what you could do is just focus on something that really needed to be reviewed thoroughly. Like if there's vague diagnosis or symptom diagnosis, or it needs clarification for the lab report, the lab results. So in that way, you could prioritize. You could put this case towards the end, so you could focus more on those cases that really needs deep digging or reviewing the medical records.
Yeah, thank you for adding that, Christy. Yeah, I think it's really important that you want to definitely prioritize. I know, let me ask you all this. I know, Roy, you're not in CDI yet, but Zenny, Andrea, and Carmen, what CDI platforms are you using? Do you have 3M360 or you have something else? What do you have currently?
3M360, and then it's manual query.
Okay, so you do have 3M360. Carmen, how about you?
That was
Or
me.
Andrea? That was you, Carmen. All right, Andrea, what do you have working on?
I'm not actually in CDI yet. I'm trying
Oh,
to get a
okay.
position in CDI, but I mean, I used 3M Encoder with the CDI boot camp that I took.
Oh, okay. All right. Okay, so you're not in yet like Roy. Okay. And Zenny?
I know we're using Coding 360, but I don't know with the CDI platform. I'm not
Yeah,
the CDI.
I think they're using 3M360 too.
Okay.
Yeah, at Henry Mayo, but you're using the 360, right? Coding. Yeah,
Yeah.
you're all doing 3M360 then. Okay.
Yes. Mhm.
All right. Good to know. I think a lot of people, because there's other companies out there that other organizations use. I know besides the electronic record, like Cerner, Epic, I know Meditech, Henry Mayo still has that. So
Iodine.
Iodine is for CDI. Yep, Iodine's out there for a CDI platform. All right. Okay. So this is an example of a non-compliant query. You never want to tell the doctor what to write. That's what a non-compliant query is. So the scenario is a 53-year-old male admitted to the hospital with shortness of breath. Past medical history includes end-stage COPD on home oxygen, hypertension, and pure hypercholesterolemia. So the query is stated this way. Dear Dr. David, the patient has COPD and uses home oxygen. He has been using BiPAP this hospitalization. Please specify and document in the progress note and or discharge summary. And they quoted chronic respiratory failure. So you're leading the doc to write the chronic respiratory failure diagnosis. You don't ever want to do that. You want to give them choices. Maybe the patient, since the patient's on BiPAP, maybe they do have an acute on chronic respiratory failure going on. Or maybe it's just chronic respiratory failure or other findings, to other explanation to explain the findings. So you never want to tell the doctor what to write. That's a leading query. All right. An example of a compliant query. Scenario, our 81-year-old female admitted from the skilled nursing facility for UTI. Patient has a chronic Foley catheter secondary to urinary retention. Also has diagnoses of Alzheimer's, dementia, and hypothyroidism. The UA was positive for bacteria, leukocyte esterase, urine culture positive for Klebsiella. So they treated the patient with IV Zosyn and replacement of a Foley catheter. So the query that we have, this would be compliant because look, what we're doing, we're giving choices, right? So, dear Dr. David, based upon the above clinical indicators, please specify and document in the progress notes and or discharge summary the type of UTI. Some considerations include UTI associated with chronic Foley catheter, UTI not associated with chronic Foley catheter, other, or clinically undetermined. Like I said, with the clinically undetermined, you need them on the POAs. Sometimes you may want to add them on other query templates. It's up to the organization's policy and procedures. Okay? So when it comes to clinical indicators, ICD-10-CM coding guidelines state that clinical indicator is a broad term encompassing documentation that supports diagnoses as reportable and or establishes the presence of a condition. So the quality of clinical indicators, how well the condition is being clarified is more important than the quantity, okay? That's the key. You want quality, relevant clinical indicators to support the diagnoses on the query question you are posing to the doctor. So your clinical indicators would include, of course, your diagnostic finding. You know, what did the provider observations, what did they document as a diagnosis that you need heart failure more specified? You know, so your diagnostic finding would include the echo for that patient. Your treatment, what are they treating the patient with? Are they given IV Lasix or IV Bumix, some type of diuretic? Is it extending the length of stay within the hospital setting? Or did it increase nursing care or monitoring of that patient? So that's why clinical indicators is so broad, but you want to make sure you capture the relative indicators to support the query question you're asking the provider to clarify. Okay. You don't need, I go by the three-legged stool, so to speak. You have your documentation of a diagnosis or not a diagnosis, but you have clinical indicators, the observations, the treatment to support that diagnosis. So that's why you want to see when you're putting clinical indicators within a query, make sure they're quality specific for that particular diagnosis that you're asking the question to clarify, whether it's for specificity or just a diagnosis that he never wrote for you, and you want to get that documented.
Also, sometimes they some facilities, like the previous facility I used to work with, they included this in the evaluation. So they will audit samples of the chart you did and check whether you're sending a quality query. And they have some benchmark or some what do you call this? On the quality, they have some requirements that they check or check off list whether you're doing a quality query, and that is included in our evaluation. So during when they, for example, give a raise, they will base it on so many benchmark, and one of them is the quality of query that you do. Others will be the productivity, the query rate, which we will be discussing later on this presentation. But just keep in mind that the facility also does audit your the quality of your queries.
Yeah, good point. Thank you for sharing that, Christy. Okay. So query key points, clinical indicators. So like I said, you can use the three-legged stool concept when creating queries that assist the CDI specialist to maintain compliant query practices. So what is it? Your diagnosis. What was documented by the provider in the record? And where was it located? The H&P stated this, okay? Your diagnostic workup. What labs or imaging results? What do they show? Is that pertinent to what you're asking, the question you're posing to the provider? And then the treatment. Was the patient treated for the diagnosis? Additional criteria, did it increase nursing care? Maybe they ended up going to ICU status level. That's a treatment. They're in critical care. So that could extend your length of stay too for that patient. Okay. So that's why when I look at a three-legged stool, I think of the diagnosis, what was the workup, and then the treatment performed. Okay, here's a CDI coding review example. 45-year-old male admitted for neck pain, involved in a motorcycle accident, hit a car and was thrown 10 feet, noted to have altered mental status upon admission and multiple abrasions to the head and trunk. Diagnostic workup reveals acute subdural hemorrhage, left pneumothorax, and multiple rib fractures from 2 to 4. Admitting physician diagnoses include altered mental status secondary to subdural hemorrhage, multiple right and left rib fractures, left pneumothorax, and hypertension. Trauma surgeon performs a left thoracostomy on admit. So the initial review. So what do you think our PDX is on this one? What do you all think? Everybody quiet. What'd you say, Carmen or Zenny?
AMS.
No, it'd be your subdural hemorrhage, Roy. That was a good guess, though.
Oh, because it says
Yeah, 'cause
admitting
they-
physician diagnosis includes. Let's go with
Yeah,
that.
yeah, right.
Yeah.
So they link the AMS to the subdural hemorrhage, right? So that's what we're looking for. And then we have an MCC on this case.
Pneumothorax, rib fractures,
The rib fractures are CCs, right? Yep.
and, hypertension additional.
Yeah, and that's a non-CC, right, Zenny?
Yeah.
And Carmen,
yes,
I know, I hear Carmen in the background. So, yeah, so our PDX is going to be the subarachnoid hemorrhage. Our MCC is our left pneumothorax. Our CC is the multiple left and right rib fractures. And then, of course, our non-CC is the hypertension, the abrasions, and whatnot, right? So our follow-up would be monitoring for additional MCC or CC capture. Any principal procedure performed? What was performed on this patient?
Doctor something.
Thoracostomy,
Thoracostomy.
right. So that's a
Yeah.
principal procedure for this patient. Okay. So when you're looking at the initial coding review, when you're doing that review process as a CDI, you want to know what bought the bed. Well, the patient came in with AMS, was involved in a motor vehicle crash, right? So yeah, but now the attending provider does say that the AMS is secondary to the subdural hemorrhage. And he's got all these other issues going on. So our initial review, the PDX would be your traumatic subdural hemorrhage. Your MCC, of course, they said, oh, with the imaging, they had a left pneumothorax. And then they also noted multiple rib fractures as a CC. But then your principal procedure would be your left pneumothorax for this patient, the thoracostomy that was performed. Okay. When it comes to your non-CCs, like your hypertension or even like hyperlipidemia, all your chronic conditions, they may not increase your SOI or ROM, but they're still getting treatment for it, right? They're not going to stop the blood pressure medication while the patient's in the hospital for another acute illness. They're going to still give him his blood pressure medications, his or her blood pressure medications. So you still want to capture those because what? Treatment is being utilized. Okay. So when it comes to, I put in here a coding guideline application from OCG section 2.c rule. In the unusual instance when 2 or more diagnoses equally meet the criteria for principal diagnosis, as determined by the circumstances of admission, diagnostic workup, and or therapy provided, and the alphabetic index, tabular index, or another coding guideline does not provide sequencing direction, any of these diagnoses may be sequenced first. Usually, now this is what the coders have to go by. Okay, so there are some chapter specific coding rules that the coders, when they're doing the final coding for those patients once they're discharged out of the hospital, they may have to flip that principal diagnosis based on chapter specific coding guidelines or coding rules. Okay, does that mean that the CDI did it wrong? No. It just means that there are certain coding guidelines that the coders have to abide by. And that's how, as a CDS, you learn about coding rules. You learn about coding guidelines from the coders. And then from a coding standpoint, the coders learn CDI, clinical indicators, from our side as a CDS. Okay, here's
But,
one more example.
Going back, do you think there is call this a potential query
Oh,
for
yeah.
this case.
What do you think it may be, guys? You have an idea? Lenny or Carmen? No?
Okay, let me tell you. Potential query would be the altered mental status, right? It could be encephalopathy, but since encephalopathy is a high risk for denials, so you just want to make sure this is just admitting documentation. So follow it up and see if it's really an encephalopathy, because I know it says altered mental status secondary to subdural hemorrhage, but the altered mental status itself, is it encephalopathy? Did it go away after, let's say, they did some treatment for the subdural hemorrhage? So that is just something that you need to follow up and
Right.
see. At least encephalopathy itself is a CC. If you it's more specific, then it becomes an MCC. But just follow it up and see if it could be a potential quality query for encephalopathy.
Right.
Yeah, and sorry
And
about that. I was
go ahead.
sorry, I just had bad reception. And also always to remember if the patient is going back to baseline, then that means that it's not encephalopathy. Yeah.
Yeah, that's right. Yes.
Right.
And
Correct.
Andrea, just an FYI, when I had I know you're going for interview, right?
Yes, next week.
Next week. Yeah.
Oh, good for you.
Because when I got interviewed, they gave me scenarios, and one of the scenario that was given to me was encephalopathy. So like Carmen said, there should be a documentation back to baseline before you could back to baseline mental status before you could query for encephalopathy. So that's one of the scenario that was given to me during interview. And
Yeah.
as we get along, probably it could refresh my mind on what kind of scenarios they are asking.
They usually
It's
give,
usually, yeah. Mm-hmm.
yeah, I know encephalopathy and sepsis is another one. They
Yeah.
give you, if a patient comes in with pneumonia and then they're, look at the lactic acid. So you want to make sure you brush up on the clinical indicators for sepsis. Also, I think the other one was a CAUTI, catheter associated UTI. I think I remember doing those in prior positions. So
Mhm.
Thanks for the tips.
yeah,
Mhm.
you're welcome.
Need all the help I can get.
All right. Okay, let's look at this review, this second example. 76-year-old female admitted with fever, redness to right anterior chest. Patient recently had a dual chamber permanent pacemaker insertion 4 days prior to admission for sick sinus syndrome. So the attending provider diagnosed the patient with cellulitis of the right anterior chest wall, rule out post-op wound infection from pacemaker, and they started IV antibiotics and CT surgery consult for pacemaker check. So I think I have the same setup. So yeah. So what's our PDX here for this patient? What do y'all think?
The cellulitis of the upper.
Yes.
Yeah, cellulitis, right? Yeah. So is there any, there's no, let me see, I'm looking, there's no MCC, right? Or no CC at this point in time. Okay. Non-CCs? I don't think we have
No.
any. Well, the sick sinus syndrome.
Six sinus syndrome. Yeah.
Yeah, you can
Oh,
add that as a non-CC, right?
Mm-hmm.
So, what do you think would be a query opportunity here for this patient? You would need further information though, right? You need further documentation, but the potential query that I'm looking at would be your rule out post-op wound infection, right? Complication,
It's a complication code.
right? So it's a
So-
complication code.
It could be
Yes.
a complication. Yeah.
Yeah, you want to see what the CT surgery consult writes, or interventional cardiologist might have done the pacemaker, whoever the consult is. Keep an eye on that to say, oh yeah, maybe, or yay or nay, is it a complication code or not? An infection related to the procedure, the device itself. Okay.
Mhm. Yeah. And sometimes, you could also see if they do a procedure, like they will take it out and transplant another pacemaker. So, and if the doctor will say ruled in post-operative wound infection from pacemaker ruled in, then you have a CC, which is the cellulitis.
Right, because then your post-op wound infection would become your principal primary diagnosis on this case, and your cellulitis would be a secondary diagnosis that you can capture, and it would be a CC.
Exactly.
Right.
Yes.
Okay. Very good. So we said the PDX right now would be our cellulitis. We don't have any MCC or CC. The non-CC would be your six sinus syndrome, and then your follow-up notes. Okay. And that's where the coding guidelines, complication codes, coding of complications of care can be very challenging, especially with post-op complications. There's no time limit on post-op complications though, guys. If a patient had a knee replacement done 20 years ago and now all of a sudden they're having redness, weeping, or they have an infection going on, that patient's going to be admitted probably for antibiotics and maybe removal of the prosthesis if it's infected. So when there is doubt or conflicting documentation within the medical record, you always want to query the attending provider. I firmly believe that attending provider, he's, like I said, he or she is captain of the ship, right? Because they're the ones that are going to create that discharge summary at the end of the stay. They're in charge of that patient's care. So you definitely want to query if it is a post-op complication or not. If sometimes a trauma surgeon or a surgeon may be the attending provider, so that is very helpful in that respect, because you're going right to the horse's mouth who did the procedure for that patient. Okay. All right. Okay, you guys want to take a quick break?
Okay.
It's, what time is it? It's almost 9:33.
9:33.
Yeah, 9:33, right? So you want to do a 10-minute break?
Okay.
How's that sound? We'll come back at 9:45 Pacific time.
Yeah.
Okay, sounds good. Thank you.
All right. Let's get rocking and rolling here then. All right. Now we're going to go through general coding guidelines. I gave you a little snippet on the examples of some of the general coding guidelines as a CDS, what we review, and the coders, what they abide by. Okay. So general coding guidelines, they need to be understood by every clinical documentation integrity specialist. Coding clinics offer advice in relation to the coding guidelines and are updated quarterly. So there's a lot of stuff going on all the time when it comes to coding, right? CDI and coding, there's constant updates from the coding rule with the coding guidelines. And the different advice that's offered through coding clinics. So we play, learn, and grow together, because as a CDS, you're always learning something new. Even the years that I've been doing this, you always learn something new. There's always some changes going on. And now with CMS, they update the ICD-10 CM diagnosis codes every 6 months now. You know why they changed it? It used to be annually in October, every October 1st. They changed it because of the COVID pandemic that we entered. And they didn't have any codes for the doctors to submit their bills, as well as for the hospitals to submit their bills when we had a COVID-19 virus patient that was critically ill. So now they do code updates April 1st and October 1st every year. So now we even get more changes happening, not just once a year, but twice a year, as well as all the coding clinic advice that's out there every quarter. So let's dig into some of the ICD-10 CM coding guidelines. Your PDX, also known as principal diagnosis, also known as primary diagnosis. This is the condition established after study. So what do I say? What bought the bed? That's what we look at. So if you have two diagnoses that meet that primary or principal diagnosis definition, focus on the diagnosis that drives the treatment. Everybody tells me very rarely do you have two diagnoses that meet the primary principal diagnosis definition. And it should rarely happen based on coding rules. However, sometimes it does. So you definitely want to see, okay, what's driving the treatment out of both those diagnoses? That's what's going to be your PDX. Now, your SDX, or your secondary diagnoses, they need to affect patient care somehow. Usually it's clinical evaluation, a doctor's physical exam or a consultant physical exam. Therapeutic treatment, are they given medications for that diagnosis? Are they doing diagnostic procedures or testing? Are they doing imaging, x-rays, CTs? Are they doing lab testing? Is it extending the length of stay for that patient to be in the hospital? Or is it increasing nursing care and or monitoring for that patient? You know, so that's why you want to see the secondary diagnosis. Like I said, the perfect example, hypertension and hyperlipidemia, both examples, they're not going to stop their blood pressure medicine or their cholesterol medicine while they're in the hospital with an acute illness. They're going to keep giving it. So yeah, they're getting therapeutic treatment for those chronic conditions. So that's where you can capture those as a secondary diagnosis. Two or more interrelated conditions as the PDX. So when there are two or more interrelated conditions, meaning they're coming from the same major diagnostic category chapter or MDC, like your MDC4 example is respiratory. That's MDC4. Okay. And they're meeting the definition of PDX. Either condition may be used as the PDX unless the coding rules apply. If the coding rules say that, no, you have to use this one, you have to use pneumonia instead of COPD exacerbation as your PDX, because there may be specific chapter coding rules for the coder to abide by. Okay. So that's why coders are very helpful for the CDSs in that respect, because they help us learn all these different coding rules and guidelines out there. Another coding guideline that CDSs should be familiar with are combination codes. There are numerous combination codes in ICD-10. There are so many of them, I can't even think of all of them. But their documentation, cause and effect, right? Those are some of the combination codes. And then they're classified two diagnoses. Could be a diagnosis with a manifestation or a diagnosis with an associated complication. And usually what comes to mind on those is your diabetes codes, you know, diabetic with hyper or hypoglycemia, diabetic related to CKD, or is it related to, hyperlipidemia? All right. So those are some of the combination codes that I think of right off the bat when I'm looking at this particular coding rule. Your codes for symptoms, signs, and ill-defined conditions. You usually never want a sign or symptom code as your principal diagnosis or your primary diagnosis when a related definitive diagnosis has been confirmed. So example, this is what I mentioned earlier today, this morning. Syncope due to complete heart block. Well, your complete heart block would be your definitive diagnosis, right? They're attributing the syncope to that complete heart block, and they're going to take care of that complete heart block, hopefully with the pacemaker and the patient gets while in the hospital. So now your principal procedure guideline states it's a procedure that affects the DRG assignment. Now, certain procedures like your EGD or colonoscopy may not affect or change that medical DRG assignment to a surgical DRG assignment. So principal procedures, it's like they're doing a definite, they're fixing that problem, that diagnosis, that medical diagnosis. Big things that come to mind on that are your fractures, right? Your fractures, more than likely, hip fracture, a femur, femoral neck, ulnar or radial tibia fractures, they're going to have to do some procedure to fix that fracture. So all your orthopedic procedures, most of them will have a surgical DRG assignment. Okay. Sometimes, like with your clavicle, if you have a broken clavicle, they usually very rarely do any procedure for that. It's just it's non-surgical management. So they'll do medical treatment management. All right. Present on admission, POA status. This is a key indicator to establish what conditions were present on admission or what conditions occurred during the hospital stay. Now, it's really important, like I mentioned, about your hospital-acquired conditions or HACs. If there is a HAC on the case, on your coding, it's excluded from your severity of illness and risk of mortality data collection. It can also affect reimbursement. So if a patient comes in with AMS, say they have E. coli UTI, an elderly gentleman in the middle of the E. coli UTI, he's confused and he tries getting out of bed and he falls and breaks his hip. Now he has to have surgery. So basically, as a hospital acquired condition, we kind of like caused that to happen because we didn't keep them safe in the hospital setting. So this is why that surgery may affect reimbursement for the hospital. They may not get any money. And usually, Christy, correct me if I'm wrong, usually the hospital will pay the surgeon to do the procedure for that patient.
Yeah.
Because we caused
That's
that.
right. Yeah, that's right. Because CMS or other insurances will not pay the surgeon for the surgery that they did. So the hospital really loses the money because they will pay the surgeon if they do surgery for the patient. So that's why
Right.
it's like it's important also that like for example the patient what do you call this had stage 4 or what do you call this
Pressure
decubitus
ulcers.
ulcer. Yeah, pressure ulcers, right? So if for example it wasn't documented that it was present on admission or it wasn't even mentioned on the H&P, and then later on the doctor will do debridement, excisional debridement. So the hospital will not be paid. It's an MCC for stage 3 and 4. Hospital will not be paid extra for that major comorbidity, as well as the doctor. So it's important that we ask for is it present on admission. So and like for example the nurses in my previous facility, they have a documentation for a wound assessment, and they have their, like for example, decubitus ulcer stage 3, and they have like beside it POA. So you don't really need to ask the physician, since the nurses already documented that it was present on admission. The only thing with the pressure ulcer is what the doctor should document is the location. The rest you could get it from the nurse's notes or from the wound care nurse. So, but present on admission is very important in this case. So the the hospital or the doctors won't be demonetized when it comes to reimbursement. Another thing is like the respiratory failure. Let's say the patient came with a CHF, right? So the patient's having shortness of breath. They're doing, if the patient's also has a renal failure, so they're doing dialysis. And the third day, the doctor will write acute respiratory failure. So you want to check, was this present in admission? So you could also one of the career opportunity, like in our facility, is very important for the acute respiratory failure to find out whether it's present in admission. So you just need to have the clinical indicators, like the patient was short of breath or the O2 saturation was this, and the patient was given like O2 4, 5, 6, above 8 liters of oxygen on admission. So that would be your clinical indicators to query for present in admission.
All right. Thank you very much, Christy. Appreciate that. Okay. And then complications of surgery or medical care. Like we said, if a patient is admitted with an infection post-surgery, the complication code would be listed as your principal diagnosis. There's no time limit on complications, but the provider documentation must link the complication to the procedure or surgery performed. And that's very important. That's why complication queries can be a little difficult, because you don't want to ding the doctor, the surgeon, or the physician who completed that procedure or surgery, right? Because then it's a quality issue for them. Because all the CMS and other insurance companies, all your commercial payers like Blue Cross Blue Shield, Aetna, United Healthcare, they tally the trends for surgeons. And so does Medicare, right? Medicare, Medi-Cal. So they're going to tally this to say, okay, because it's part of all the patient safety indicators that are out there. And it's really important that, mistakes will happen, right? Risks will happen. That's part of having surgery. You may develop a risk. You may end up having a stroke after a cardiac cath procedure or after an ablation or something, right? You're for AFib or a flutter. So, you have to look at that. That's why you always see the informed consents with documenting all the risks, even potential death, right? For any surgical procedure. Unfortunately, risks, they'll develop. They can develop complications with any procedure performed. So that's why it's difficult sometimes, but you got to look at the patient's overall health too, right? When you're doing procedures. Okay, a couple other coding guidelines we have in here is admission from outpatient surgery. So if a patient was direct admit to the hospital due to a complication that occurred with the outpatient surgery, then of course the complication is assigned as the PDX. So say for example, a 80-year-old went to have his or her eye cataracts removed and had lens implants put in, right? All of a sudden after surgery, they're having a rapid heart rate and they find out that the patient's in rapid atrial fibrillation. So of course they're going to whisk him over to the ER and say, all right, you need to take care of this. He can't be discharged, or she. So that would be what brought the patient into the hospital setting, would be that rapid atrial fibrillation diagnosis. Now you're uncertain. Go ahead, Christy.
Yeah, I'm just saying that if that happens, so AFib will be your primary diagnosis, but the surgical DRG is going to be carried over to the inpatient. So if you have atrial fib and the patient had cataract, so it's going to be a surgical DRG because of the cataract. So it's reasonable to have that because, like I said, whatever was done on the outpatient side, whatever diagnosis, it carries over to the inpatient admission. Right, Ms. Zenny?
Yeah.
Zenny and Carmen are coders.
Our experts.
Our experts, that's right.
Oh, no.
Oh no.
All right. One of the other coding guidelines on certain diagnoses, your possible, probable, suspected, likely, that may be documented by the physician can't be coded as if the diagnosis exists. This only applies to the inpatient setting though. However, you want to make sure that they carry that diagnosis through the record consistently in the notes, as well as the discharge summary is key. Okay. If they're dropping a diagnosis that's, they said probable or possible, you definitely want to clarify. So that's a potential query opportunity. All right. If it's not in the discharge summary, because the organization I work for currently, if it's not documented in the discharge summary, they want it clarified. They want to know, because it wasn't consistently in the record. So we're usually sending a rule in or rule out, or, is it clinically significant, depending on what type of diagnosis it is. So that's why it's really important. Like I said, they're very strict with their query policy at the organization I work for, because they, like I said, they query everything. So I think I could see the doctors getting query fatigue big time, but it's like, okay, they do, that's their facility policy, so that's what we do. So anyway. Okay. All right, let's talk about the procedure coding system. Coding guidelines, the ICD-10 PCS. All the guidelines are in your CMS website. There's over 1,000 pages. I think it's like close to 1,200. So yeah, I didn't put them all in here. So when you have some free time, if you want to review the PCS guidelines, be my guest at www.cms.gov. They'll give you tons of information. This is a new coding procedures. It came effect when ICD-10 came in effect with the diagnosis, your CM medical diagnosis codes. And the 4 cooperating parties, organizations, your American Hospital Association, of course, your AHIMA, American Health Information Management Association, CMS, Center for Medicare and Medicaid Services, and your National Center for Health Statistics. They decided, let's create new procedure codes. The reason being, the old CPT, ICD-9 CPT codes didn't give you a lot of specificity. So they created the ICD-10 PCS coding rules for inpatient only. And the X section is all the new technologies that are available for patients, whether it's administration of a new chemotherapy drug, whether it's a new cardiac procedure. They have those leadless pacemakers now they're putting into patients. They're not making that pocket anymore in the chest, or the abdomen and doing all that and putting leads in. They have this little new device now that can be inserted. And I don't know a lot about it. I couldn't tell you exactly all the specifics, but that's out there. It's available. So they started, that's a new technology, for providers out there. So now they can capture that information as well. And then the other thing is too, COVID, right? So I just thought about that, right? Our COVID-19 codes, the U code for COVID. All right. Based upon HIPAA requirements, though, so all the ICD-10 PCS coding guidelines, of course, it's all based on HIPAA, like everything is in healthcare. All characters must be specified in order to provide a valid procedure code. And there's a lot of different indexes and tables available that assist the coders to obtain the most accurate procedure code for billing. And this is just an example of what a ICD-10 PCS code would look like. As you can see, it's alphanumeric and it's 7 characters. And always your first section, your first character is section. It always defaults to a 0. Okay. And inpatient, usually it's your med surg section. Okay. And it's only used for inpatient right now. They're not using it on the outpatient side. Okay. So of course, for this lumbar spinal fusion, we have the character 1 is section, which is med-surg 0. Then your body system is your lower joints, and that's designated as S. Root operation is the fusion, and that's G. And then your body part, what do they work on? What do they fuse? It was your lumbar-vertebral joints. That would be number 1 for that character. Character approach is open, so it'd be a 0. Your device, interbody internal fixation device, is 3. And then qualifier, what approach they used. Is it posterior approach, posterior column? Okay. So that just gives you a little snippet idea of what the procedure code would look like. And when you're walking through, when you're using your 3M, it'll walk you through each one. Okay. And that's why we mentioned about the root operation, Christy and I mentioned. That's what we really need to focus on as CDS, is to make sure that's correct for that procedure code, because that'll definitely help the coders after the patient is discharged to capture those procedure codes accurately. And then this is just a code table. So remember I said the coders have tables and indexes. This is an example of a code table. And the section, as you can see, 0, medical and surgical. And then your body system is central nervous system. And that's 0 as well. And then 1 is bypass. So the bypass example is altering the route of passage of the contents of a tubular body part. Okay. So when you're doing root operation, there are so many different root operations available. That's why it's helpful for a CDS to have a little cheat sheet. When this all first came out in 2015, it was very, very, very confusing. So the doctors do not have to write that they did, bypass of this. They're going to use whatever verbiage they use in their op reports, and then it's up to the CDI encoding to make sure the coder's final say, right, to make sure that they accurately capture that root operation. Then, of course, you have a body part in here. This is the cerebral ventricle or spinal canal. And then approach would be open. Your device, it could be autologous tissue or synthetic or non-autologous for either one, depending on what body part you're working. And then the qualifiers is it your nasopharynx, mastoid sinus, atrium, blood vessel. So you could see all the different tables. That's what the coders will go by when they're setting up, they're creating their code for the procedures. This gives them the pathway to walk through. And you know what, just an FYI, the Hagen Academy, I don't know if you all heard of them. They're really good. They do webinars every month. And for a nominal fee, they're pretty decent. But they also have a flip chart of procedure codes, procedure coding sets. And it mainly is their body, their root operation, that it's really very helpful, because that's why I was using that I still use it. So just an FYI, if you are doing CDI currently, I think it's very helpful tool to purchase and have available for your CDSs.
What is the name of the company?
It's Hagen, Haugen Academy.
HAUGEN, I think.
GEN. I can type it in the, you want me to type it in the chat?
I'll do it.
Thanks.
Yes.
Because they really they have quite a few books and flip charts available. They even have interventional radiology chart book available. Very thin. It's a brochure style, pamphlet. Really gives you a lot of information with all the vessels, when they're doing IR embolizations and things like that. Very helpful. I find them very helpful. I just, there's a lot of references for CDSs and coders alike out there. It's just knowing where to look. That's the key. Okay. All right. Now we're going to talk about our hacks. hospital-acquired conditions. So this is the current hack listing that we have from CMS. Foreign object retained after surgery. Now, there's a little caveat with that. If there is a foreign object retained after surgery and then they bring the patient back to the OR to remove it, then it's not considered a hospital-acquired condition. It's considered a hospital-acquired condition when the patient is discharged and there's a foreign body left in that patient after the surgery. They have to come back in. Okay. Air embolism, very rarely do I see that. Blood incompatibility also, I very rarely do I see that because of all the testing and the different policies and procedures that are in place. Your stage 3 and 4 pressure ulcers, that's one of the biggest ones that we look at from a CDI point of view because of POA status. Falls and trauma, now whether it happened in the hospital, that's what you want to clarify, if it's POA or not. Your fractures, dislocations, any intracranial injuries or crushing injuries are coming in, burn or other injuries. And then manifestations of poor glycemic control. I think they were going to do a change on this. I'm not really sure. I didn't have a chance to review it prior to our webinar today. But they are looking at changing this around or eliminating it. I'm not sure what they're doing, what CMS plans were, but I will look it up and I'll email everybody on that one because I know they were looking at modifying it. But this is where the patient develops DKA or the non-ketotic hyperosmolar coma or hypoglycemic coma, or secondary diabetes with ketoacidosis, secondary diabetes with hyperosmolarity, that was not present on admission. They didn't control their diabetes very well for whatever reason. So they develop any of these issues. So it would be listed as a hack. Of course, your catheter-associated urinary tract infection, or CAUTIs as I call them. You want to make sure that that patient didn't come in the door with that catheter, though, whether it's a Foley catheter, indwelling urethral, or if it's a cystoscopy, suprapubic tube, anything like that. You definitely want to make sure that you get POA status on that. Your vascular catheter-associated infection is another one. Those are your CLABSIs, where they have catheter-associated bloodstream infection. That's going to be considered a hack big time if we cause that to develop. And then, of course, your surgical site infection or your mediastinitis following bypass, your CABG procedures, is a hack. Surgical site infection following bariatric surgery for obesity. If they did a gastric bypass or they did a gastroenterostomy or a lap gastric restrictive surgery, they develop an infection following that, then that's going to be considered a hack. As well as your other surgical site infection following certain orthopedic procedures. So if they get a surgical site infection post spine, neck, shoulder, or elbow procedures, they're going to have to list that as a hack on the claim form. So, and just,
So I just have a question here. So if the patient had surgery, came in because of, let's say, acute cholecystitis, and then the patient had a cholecystectomy, and then 3 days later, the patient developed pneumonia, and so they're treating the pneumonia with IV antibiotics and probably pulmonary consult or ID consult. Would this be considered as a hack? Anybody?
what do you think? Would the pneumonia be considered a hack?
Yes.
Carmen's saying yes. Senny, what do you think?
I'm not sure. But it happened in the hospital though, post-op. So it looks like it.
That's right. Well, the only thing that you have to remember for the hospital acquired conditions, there is a list. This is the list. If it's not on the list, it's not a hack.
There you go.
So So
So it's
pneumonia is not on the list, so it's not considered as a hospital-acquired condition. So these are just the list that CMS considered a hospital-acquired condition. So if the patient develops sepsis after surgery, or pneumonia after surgery, or any other complications that are not included in the list, then it's not a HAC.
Okay, I think the reason I was getting thank you, Christy. The reason why I was getting confused, so this would be not present on admission. So if they were to get pneumonia, then it would be a POA of no or not present on
Correct.
admission.
That's right. Yes.
Mhm.
Yep. So you just need to know, like we gave you the list of the hack. So if it's not in the list, then it's not considered a hack.
Right. Okay. They may not be, yeah, like Carmen said, and Christy, if they're not POA, they didn't come in the door with that pneumonia, but they developed it during the stay, so it's a non-present on admission status, non-POA status indicator. Okay, it's not considered a hack, the pneumonia, because it's not on our list. So you always want to look back at your hack list when you're looking at stuff that aren't present on admission and POA status. All right. Okay, whose documentation counts? So when you're looking at the health record, you have consultant, you got the attending provider, and any healthcare provider on that record. It could be a physician, residents, fellows, consultants, nurse practitioners, physician assistants are also considered providers, right? So coders can obtain codes from the above listed providers, whether it's an H&P, progress notes, orders, discharge summary, a consult report, operative procedure reports. Okay. There is one exception though. When it comes to your BMI, your pressure ulcer stages, and your Glasgow Coma Scale, your GCS, may be based upon the nursing and our nutritionist documentation. Some facilities will accept nutritionists and nurses documentation if signed by the MD. That's like I said with those pressure ulcers. It's great to have a little template in there for the wound care nurses to make it electronic so the doctor can just sign off because they're confirming that they agree with the nurse's documentation or your ancillary staff documentation. Other facilities require that the documentation is authored by the MD. So again, it goes back to your facilities policies and procedures that are in place. And also, keep an eye on that because every organization is different. Like I said, the contract CDS job I do now, the nurses have the documentation, the wound care, they document the present on admission, yes, and the pressure injury or ulcer. It's pressure injury is the new lingo for pressure ulcers. But they give you the stage and the site, and the type. And then the doctor we would have to send the query to the doctor to confirm that it is, he agrees with their assessment, with their findings. So that's why we don't have a template per se at the current organization I work with. But we did have a template at Henry Mayo that we created with the wound care docs, so with the wound care nurses, so the docs can just sign it off, and all the hospitalists love it because it's like, yeah, good. I don't have to. I said, you just got to make sure you put it in the discharge summary at the end, and that's helpful to have that available as a template. It's like a query template for the wound care nurses. Okay, attending versus consultant. So which provider's documentation matters the most? So if documentation from the consultant conflicts with the attending's documentation, the CDI specialist would need to seek clarification from the attending provider. This is when a query is posed. So say, for example, a cardiologist comes in on a patient because he came in with chest pain. The cardiologist is saying, no, it's only acute coronary syndrome. He has CAD with unstable angina or other form of angina pectoris. And then the attending is writing an NSTEMI. So you definitely want to clarify, was the NSTEMI, is it truly an NSTEMI or is it just CAD with unstable angina or angina equivalent? Okay. And the attending is the captain of the ship, like I always say. So whatever he states goes. Okay. All right. Any questions on this, on the coding guidelines? Anything else? Hacks? We all good?
Yes.
Yeah?
Yes.
Oh, okay.
Yes.
Okie dokie. I just want to make sure you're all out there. All right. DRG validations. This is the fun stuff now. DRG validation, also known as a DRG mismatch. What next? So what do we look at? So the validation mismatch process occurs when the final coding DRG does not match the CDI final DRG. And you will see this. It's nothing new. This is what happens. Because sometimes as a CDS, you may not see that discharge summary, okay? You only saw that patient twice on admission, and then they did another follow-up, and then the 4th or 5th hospital day, they were discharged, and you never got to see them because it's wiped off your list, okay? Your worksheet, your work list. So this is where you have a discussion between the coder and the CDS, and what is the mismatch? What are we missing, or what was done that we might have, maybe they had a procedure done. We didn't capture that because maybe we didn't have the op report available, the full op report to code that procedure. Was it an MCC or CC capture that we might have missed? We're human, we make mistakes, right? Is it the SOI or ROM, severity of illness or risk of mortality data? You know, maybe they have an SOI of 3 on the case and we only have a 2. So what did we miss? Maybe we missed capturing a secondary diagnosis to up that SOI data point. Or is it the principal diagnosis? You know, that can change too. Right? So
Yes.
these are some of the items that you may see where there is a DRG mismatch or validation between the coder and the CDS. And usually by the end of your discussion, the coder and CDS, they come to a mutual agreement, and then we update, okay? So if there is no agreement, though, between the coder and the CDS, then some facilities may have an escalation process in place. So an example of a escalation process is the case is referred to the director or manager of HIM and or CDI. Okay. And then some facilities escalate the case to a physician champion. Okay. So usually out of all the years I've been doing CDI, usually the coder and I, we always come to a mutual agreement. Very rarely do we have to escalate it. With my current contract job, there was one case that I asked the coder, she asked me about, you know, a post-procedure code for medical diagnosis. And I was like, you know what, maybe we can use this code. Because I was doing some research and going through the 3M, and I was like, you know, hey, how about this code? What do you think? Let me know, or, you know, you want to turf it over to your manager. And she goes, and even she spoke with her manager. Jennifer was a coder, and she goes, Anne Marie, my manager Maria says, yeah, let's use your code. That'll be even better, and then we get a higher DRG assignment with it. I said, perfect, thank you so much. So you know what? I usually don't. I don't challenge the coders because they know coding. That's their job. They've been doing it for years, you know. But sometimes if I can find a better diagnosis code for a particular case, I'll ask them. I was like, hey, what do you think about this one? You know, what do you think? You want to ask your manager, you know, would this be a better code for our principal primary diagnosis? Okay, so DRG validation, remember, the coder has the final say. They're in charge of completing the final coding for each account. So it's not up to the CDI to complete the final coding. It's up to the coders. Their name goes on that claim form. That's why they have certifications to do all that.
Sad.
Exactly, right? Exactly. I know a couple of our CDSs that when I worked with Zenny and Henry Mayo, they would challenge the coder. I was like, what are you doing? They have the final say. Why are you asking? Why are you challenging their diagnosis when the PDX, it's appropriate based on what, the review was completed.
Good
So,
thing there's a treatment guideline.
yeah, you got to go according to the guiding, the coding rules, the guidelines out there, So,
And I
you know
think
what?
it's one of the major challenges with coding and CDI because
Yes,
yeah.
yeah, it is a major challenge, and that's unfortunate. It shouldn't be because we're all on the same team.
exactly.
I tell everybody, I was like, hey guys, we're all on the same team.
Yeah.
I said, you're strongly believing that pneumonia should be the PDX and not the COPD exacerbation. Okay. But the coder has the final say. You abide by what they know because they know the coding rules. From a clinical documentation standpoint, we know the clinical aspect.
Exactly.
We're trying to help the coders. We help the providers. We have, as a CDS, you have a dual role, right? You educate the providers on diagnosis specificity with the clinical indicators you review and you abide by, whether it's a Pinton and Tang book or an Actis Pocket Guide, whatever it is, right? And then we look at, and the coders look at the coding rules. And there are certain coding rules they have to abide by. So it's like, why get into an argument or a disagreement with your coder when we're here to help each other? Okay. And I think people, sometimes CDSs forget that. They got to, put it in your brain that it's like, coders have the final say. Their name is on there. I don't want my name on that final coding. I have no idea what I'm doing. I don't know coding that well. I mean, I know general coding guidelines from a clinical documentation perspective, and that's the key. Okay. And I think that's when you're trying to get the team to work together. I mean, it's very difficult sometimes, and it's unfortunate is what I'm going to say, because you know what, like I said here, discussions about DRG validations on the bottom of the slide, CDS just share clinical evidence or the clinical indicators, which are supported in the medical record with the coder. And then the coder shares the coding rules associated with secondary diagnosis that may be listed within the account by the provider. Okay. Or whether it's a secondary diagnosis or what bought the bed, the principal diagnosis, primary diagnosis. Things can change. And when you're reviewing a record concurrently as CDIs, that's what we do. You may not see what occurred, like an op report, a procedure was performed, but the patient was gone by the time we got back to that follow-up, subsequent continued stay review. Okay. And that's where the coders, they're helpful. I had one coder, she emailed me, she goes, oh, with the anemia, we have CKD stage 3A listed. I said, really? I went back and I'm looking for it. I didn't find it. But I'm going according to what the coder told me. I was like, thank you very much. I'll withdraw the query. Perfect. Because I couldn't find CKD3. Well, you know what? Sometimes you miss those. The reason why anemia could be associated with CKD, because it's automatically assumed that CKD and anemia can be automatically linked based on coding guidelines. See? So I missed the CKD3. The coder pointed it out to me. I withdrew the query and updated the anemia with the CKD diagnosis code. Okay. So that's why it's always helpful. You always want to work. You're a team. CDIs and coders are a team, and it's really important that you do work together and not work separate or apart. I don't understand some of these organizations out there. They keep the coders siloed, and they never talk to their CDI teams. And I don't. That's not a good way to have your CDI program run, to be honest with you.
Yeah, and some also with the DRG validation is that some facilities have a mismatch CDI. The role of that CDI partly is mismatch. And when we do that, what is good with that facility I work with is that CDI is also a coder. So whenever there is a mismatch, sometimes it's just simple, it's like the vent hours, right? So if the patient is has sepsis and it's more than 72 hours, so that would change the DRG. and sometimes the coder will miss that, and the CDI caught that. So there would be at the end would be a mismatch. The coder will code this, and the CDI coded this one. So there's a mismatch there. So this a person will just point out to the what do you call this, to the coders. See, the patient was on event for this, for this number of hours. So that's easy fix. Or if there is a surgery, sometimes the coder will not um, use it, but the CDI will see it's there. So that would also be an easy fix. The only thing is when it comes to like PDX or the CC, because I'm always saying that there are people or there are facilities that they don't talk, the coders and the CDI don't talk to each other, in which my previous facility is was doing them. So it's important that it's we escalate it to the manager, and the manager will talk to the manager of the coders if there is some discrepancy. And then also, like I said, that our we call this the mismatch CDI. So he has a knowledge about the coding lines. So when he presents it to the coders, he will attach the guideline, so the coder know where the CDI is coming from. So there's just so many things with the assignment of DRG, but like Anne-Marie said, it's always going to be the coders who has the last say.
Right. And you got to keep that in your brain too, as a CDS. Okay. So further about DRG validation. So when it comes to your SOI, ROM, and POA statuses, there are certain DRG software programs that are part of the CDI software program that must match directly between the CDI and coding programs. So with the 3M 360 that I use, the 3M is embedded in the 360 CDS. And also the coder uses the same thing, the 360 coding. And you can see with your MSDRG assignment, you have on top in the software program, and then you have the APR DRG assignment, and that's where your severity of illness and risk of mortality data is, your SOI and ROM. And then your POA status is usually listed on the side of the diagnoses that you put into that encoder. So, you always have that information available to you. Now, there are certain facilities that may not have that APR DRG in their 3M encoder. Okay, they only have the MSDRG assignment. So just be aware. Like I said, other facilities, because you have to pay for that. You have to pay extra for that APR DRG assignment through 3M. So some smaller community hospitals may not have that SOI ROM data for you. They only have the MSDRG code assignment. And then, of course, your procedure coding pathways can assist the CDS to understand how the coder came to that procedure code that may be different than the procedure code the CDS captured. And that could be. It could be something so simple as, is it an open or is it a percutaneous? Or is it a percutaneous endoscopic, which is your LAP, right? The laparoscopic is percutaneous endoscopic code for your procedures. So, sometimes they start as a laparoscopic and they ended up making them open. They converted them. So there's another procedure code for that in the 3M encoder that the coders that they have to use, they have to add in. So to the procedure codes. So, there's little things, but that's why I said you're always learning as a CDS. And it's really important that you maintain an open mind when it comes to CDS and learning codes and understanding the coding pathways, understanding all the coding guidelines. Because you're constantly learning in this job, that's for sure. But it's fun. You feel like you're playing detective. It's like, whoa, what's this? Wait a minute. They have a heart failure. Wait a minute. Are they on medication? Where is it? Where's the list? Where's the bar? And it really is a fun job to do. So, okay. let's go through this DRG validation case study 1. 56-year-old male admitted with nausea and vomiting, diagnosed with a partial intestinal high-grade small bowel obstruction. Further testing indicates a tumor in the duodenum. A biopsy performed indicates metastatic disease. So the final CDI coding was GI obstruction with the CC, the K56 dot as the principal diagnosis. But then the coding final DRG was the digestive malignancy with the CC. So the discussion here, after the case study was reviewed, the PDX is what bought the bed. So you would refer to the coding rule based upon principal diagnosis definition, right? Since the biopsy was positive for Mets disease, this information was not documented by the attending provider. Therefore, a query was sent to the attending provider to confirm the clinical significance of the Mets disease. Thus, the coding final DRG was submitted as final billing, okay? So we sent a query because, oh, they got a biopsy, they had the path report, it's Mets disease. We want to confirm that they agree with that path report. And that's why CDSs will send a query to the provider to say, hey, do you agree with that path finding of metastatic disease for this patient? Once that query was answered, that's why the coder said, nope, it's going to be the Mets disease instead of the GI obstruction, because your Mets disease is basically what caused the bowel obstruction to occur, right? So that's why you want to have your Mets disease as your primary diagnosis, and then your bowel obstruction would be a secondary for this patient. Okay, so that's why things change. You may not see, maybe we didn't see the path report on our last review. Maybe a query wasn't needed, but the path report was in there and it was in the discharge summary. So the coder saw that, but we didn't because the patient was discharged. So we never saw the discharge summary. So then the coder will email the CDS and say, hey, we have a DRG mismatch. I coded the PDX for digestive malignancy. Can you please review? The path report was positive for Mets disease. Okay, so this is how you have to, this is what the thought process is. When you're looking at a DRG mismatch or a DRG validation, it's like, oh, okay, what if I miss something? Hey, we're human. We're going to miss stuff. That's what we do. You know, we're all human here. But if there's further information in the record that we didn't have on our last review, then that's when you go back in. So it's education for both, for both sides. Okay. Okay. This is another case study for DRG validation. A 69-year-old female admitted with cardiac arrest, status post-outpatient bronchoscopy. During bronchoscopy, fine needle biopsy performed on the right middle lung lobe. Hemorrhage of lung tissue occurred, leading to hypotension and PEA arrest. Resuscitation performed during procedure, with EKG showing acute anterior lateral myocardial infarction. Cardiology was consulted and confirmed acute MI as well as cardiogenic shock. Treatment initiated with intubation on mechanical vent, NorEp drip for shock, and transferred to ICU. So the attending physician on this case, the pulmonologist, indicates bleeding during bronchoscopy, which led to PEA arrest and acute myocardial infarction. The internal med physician indicates cardiac arrest due to intra-op complication of hemorrhage, sepsis, and septic cardiogenic shock. So, with all that information in there, this is what we looked at. The CDI final DRG was 919, complications of treatment with an MCC. Okay. Which was the intra-op code for J9586. I should have spelled it out for you guys. I apologize for that. But the final code says, no, it's infectious parasitic diseases with the PDX because they had sepsis. So, and that's your 841.9. as your sepsis unspecified code as the PDX. So then the discussion, based upon the case study, what bought the inpatient bed was the cardiac arrest with acute MI that occurred during bronchoscopy procedure. Okay, intra-op complication. And then you refer to complications of care coding regulations. Thus, the CDI final GRG assignment was agreed upon by the coder, coding supervisor, and HIM director on this case. The reason why now the coder uses sepsis, but guess what? If you look at this case study, is there an infectious source? The internal med is writing sepsis, but is there an infectious source on this case?
No.
There's no infection source. No.
That's right. That's right. Okay.
Sorry,
So that's why. Go ahead.
I'm saying there's no infection source, just a cardiogenic shock.
Right, right. It's more cardiogenic shock, right? And it's complication because it was intra-op bleeding during the bronch that caused the cardiac arrest, cardiogenic shock, and acute MI on this patient. So the discussion was had between the coder and the CDI, and even the supervisor says this is a really great case study to review within our coding CDI meeting. And it was brought up. This was one of my cases, and I believe in Henry Mayo too. And it very sad state of affairs because I know the pulmonologist, and unfortunately this patient did not make it. So the pulmonologist really took it really hard. He never lost any patient with all the bronchs that he does. He was an interventional pulmonologist. I mean, he's very expert at what he does. And when he lost his patient, he was just brokenhearted because he never lost anybody. And unfortunately, this patient they found out that this patient did have an underlying, I don't know if it was like a little aneurysm or something. There was something structurally wrong with her heart. And that's, and I think that's what caused the MI, the cardiac arrest and whatnot, because there was structurally something wrong with the heart. Even the cardiologist stated that on this case. Unfortunately, and it wasn't caught with the pre-op testing that was done for this patient because the EKG didn't show any issues or the echo really didn't show anything. So it was very minute that they couldn't pick it up on the diagnostic imaging they performed for this patient prior to doing the procedure, the bronch procedure. Okay. So just keep an eye on that. Sometimes the coders may not have the correct ERG too, right? And that's why we're here to help too, because we're giving them the clinical evidence in the record, and you know what is pertinent. And for that internal med doc to say, oh, it's sepsis and septic shock. Well, you know, as a CDI, I would definitely send a query to him. It says, where's the infectious source? This patient didn't have any infection, you know, so why are you saying the patient is septic? Okay, so that's another piece of the pie when you're looking at cases concurrently. Okay.
Yeah, and another like this is a DRG validation with the coders, but this could be a DRG validation with the doctors. It's like if he's been documenting sepsis all
Right.
throughout, and then you cannot find any infection in the first place, and then also the vital signs does not support, the labs does not support the diagnosis of sepsis, then you could query the doctor. Are you sure it's really sepsis? No, it's going to be in a way that present the doctor the clinical indicators that like source of infection none found, and then check
Right.
what do you call this, enumerate the vital signs. Let's say the blood pressure was low, but was the heart rate, or was the patient running fever? Was the LWBC elevated? So if it doesn't fit the sepsis criteria, then we could also query the doctor. Is it sepsis ruled out, or based on the above documentation clinical indicators, was sepsis ruled out or sepsis still ruled in due to, let's say, you could even ask sepsis ruled in unknown etiology. They can say that because they still
Right.
really think the patient is septic. They just don't know what is the cause of the infection. So they can still say that. But by doing that, at least you're also making it clear for the coders towards the end that the doctor did rule it in as a sepsis. So at least there's a backup documentation, the record, um,
Right.
that the patient really did have or did not have sepsis. So
Right. And that's where you can use a clinical validation template, for your query on something like this. Because, and then even some of the choices that could be listed, like Christy mentioned about the ruled out, or it's still ruled in, and please specify additional clinical indicators for this diagnosis. That's one of the comments, one of the choices that I've seen on some examples from Mahima and Actis with the CDI query templates in their toolkits. So you definitely want to clarify, sepsis, especially all the time. If they write it at the beginning and then they drop it off, the diagnosis is dropped from their documentation. It's like, yeah, you want to clarify if it's still present or not, or if they ruled it out. That's why rule in, rule out queries are really easy to do, I think, in my opinion, because you're asking them, you're giving them the clinical evidence in the records, the clinical indicators, the three-legged stool we were discussing earlier, and then, clarify. And they may say, and other explanation of clinical findings, and that's fine. They write something else down. Okay.
and this is kind of sensitive for the doctors because they don't want you to be questioning their decision or their documentation. uh, we as a clinical documentation, we don't see the patient, they do. So that's why you just want to clarify it. The most common that when I used to work is the severe sepsis with acute organ dysfunction. So
Yeah.
because that changes the whole DRG not DRG but ICD code, I think, for acute organ dysfunction. This one increases the severity of illness, but they don't document what is the acute organ dysfunction.
Right.
So that's when I clarify. Can you please specify, what is the acute organ dysfunction? Sometimes they will say without acute organ dysfunction, or sometimes they will write in the others, patient has AKI, something like that. So at least, because it is also high level of, or it's a red flag for denials or audit with acute organ dysfunction. So that's why it's imperative that we ask the doctor to document what is the acute organ dysfunction, what is what is the organ dysfunction, so that even though we get audited, at least we could present that this is what is the acute organ dysfunction. Otherwise, there is we need to validate what is documented and what is the clinical indicators.
Right. And that's definitely important. I have doctors just writing, hospitalists writing in the current job I'm in, they're writing sepsis with acute organ dysfunction. Okay. They're giving me acute organ dysfunction, but they're not telling me what the acute organ dysfunction is. So, you definitely want to clarify, make sure they're documenting what the acute organ dysfunction is. Even don't just give me the verbiage, acute organ dysfunction. That's not enough. You want to make sure you capture what is it, document the diagnosis. Is it acute respiratory failure? Is it AKI like Christy mentioned? Or is it hypotension? Is it shock? You can't just write the verbiage sepsis with acute organ dysfunction. That doesn't cut it today. They really need to specify what exactly that acute organ dysfunction is.
And it's important for them to link it, like severe sepsis with acute organ dysfunction due to AKI. They cannot just say sepsis with acute organ dysfunction and then number 2 AKI or encephalopathy. They cannot list it. They have to link what is the acute organ dysfunction. So
yeah,
that would be clear for the coders at the end.
Right. Absolutely. Okay. Hey, we're doing pretty good. Do you guys have any other questions on DRG validations or mismatches?
No.
No.
No, thank you.
All right. Okay. All right. CDI metrics. If it is not measured, how can one improve, right? Well, that's what metrics are. You always want to improve. It's continuous quality improvement. I remember back in the day when I was in nursing and critical care in back east, I was in charge of the continuous quality improvement program in ICU. I was like, yeah, that was fun. So, I mean, it's still, there's all quality improvement. Everybody can improve, right? No matter whether it's in your professional life or your personal life. We're always looking to improve. So CDI metrics, what is it really? It's a standard of measurement. That's the definition. We're just looking at measuring different items. And it's used for quantitative data collection. And the reason for it, measuring tasks over a specified time frame. So you're always looking at a cumulative, right? A trend of data, of measuring stuff. There's differences between financial impact metrics and quality metrics. So your financial impact, what is going to increase your reimbursement, right? It's going to increase dollars for the hospital. Your quality impact will likely increase your SOI, severity of illness, or your ROM, risk of mortality data. That's really important because why? Especially when you're looking at if you're doing reviews of mortality, morbidity, patients likely going to die in the hospital. You want to make sure your SOI and ROM data are really high at the highest level possible, 4 and 4, extreme severity of illness and extreme risk of mortality, that they are likely to die in the hospital setting with the diagnoses they came in the door with. So let's look at the different types here. And productivity is the biggest one. Every CDI program has productivity. And what is it? It's a calculation of number of health records reviewed by a CDI professional divided by the number of health records assigned for review within a defined period of time. Okay. So we're looking at a trend, a specific time frame. And this metric can help identify if the goal of the review rate is realistic, right? So you definitely want to make sure you have a reasonable goal for your productivity, your daily productivity scoring, the number of charts reviewed. This information can help leadership recognize when additional staff may be needed as well. And the productivity expectation is 80% of the standard 30 to 35 reviews per day, which leads to 24 or 28 reviews per day. Now, however, there are it depends on what your facility policies are when it comes to CDI metrics, okay, your productivity. Now, this one is high, on the high end. There are other facilities that they only want 16 to 21 charts done a day, both in initial reviews and subsequent reviews or your continued stay reviews, okay? You always want to look back at what your policy states in that hospital setting. There are some cases that, I worked when we were doing paper charting way back in the day, 2009, 2010, even 2011, where we had to put paper queries together. Electronics wasn't available, electronic record at that time. You had to do 12 to 15 charts a day for initial and subsequent or continued stay, okay? So an example of a benchmark that we have listed here, 20 to 35 reviews per day. Like I said, it depends on what your policy is, so you definitely want to take a look at that. And that initial and concurrent reviews. So your initials are, they just came in the door, they got admitted. And then your concurrents are, your ongoing reviews. After you did that initial review, it's going to go into your bucket and your continued stay or subsequent review list. And then you look at the next review date that you assigned. There are different...
I'm just saying that it's, 35 reviews per day. I don't know how you do that. It would be really, really difficult reviews. I don't think you can do any quality review with 35 reviews per day. I think 20 to 25 is more reasonable based on my experience. Because if before we used to do 29 per day, it's like always, you're in a hurry. You have to finish that productivity. But I feel like I'm not doing a quality review. But for me, 20 to 25 is a reasonable review per day. And usually also if you are new in the hospital, they usually give you like I think 5 to 10 reviews per day, so
5 to
that
7.
until
Yeah.
until you get used to it. And I think they'll give it, I think, 1 to 3 months. That review per day, because you're still getting used to their system and you're getting used to their process. So they give a leeway if we are new CDI in a facility.
Yeah. Yeah. Usually it's 5 to 7. I know when I started working at Cedars as a newbie, it was 5 to 7 the first 3 months, first quarter. And then they said, okay, can you hit, 7 to 10 or 6 to 10 or whatever, So it does take time. You got to understand, you got to give yourself at least 6 months to a year to really understand what's involved on a daily routine for a CDS, especially when you're learning coding. You got to flip your brain 360 degrees, because clinical does not match coding whatsoever. That's why I tell everybody, flip your brain around, because we're in coding now. Yes, we got the clinical aspect with diagnosis specificity for sending that query, but now we got to flip our brain, because coding does not match clinical. It's illogical. It's not logical. Okay. The other types in the metrics, you'll see query types, usually if it's a quality impact, financial, or clinical validation queries that you send. Query response rate and agreement rate, I know a lot of the CDI programs have that as well. They look at, agreement rate. Usually the response and agreement rate is over 90%. That's one of the benchmarks I've seen out there. When it comes to sending queries, they said we had to do 30% query rate. And I was like, excuse me? 30%? It's a little high. So this is the contract company I'm working with right now, the facility. And I was like, I said, I emailed the manager, and I said, it seems that, that's really high. That's not even in the benchmark area, from what AHIMA and ACTIS say. Usually it's 20 to 25% for query rate. But they finally dropped it down, because it was over 30% they wanted us to hit with queries. I was like, yeah, I'm not going to hit that. I said, I can hit 20, 25%. That's usually my ballpark, But when you have a really high query percentage rate they want you to hit, it's called, to me, that's trash in, trash out. Like when Christy was saying about doing 30, 35 reviews a day. You're just going through it, and it's trash in, trash out. You're not really taking a dive into it. You're not looking at it from a quality standpoint, because they just want trash in, trash out. You got to just send whatever. And finally, they did drop it down. The query percentage rate, they did drop it down to 20 to 25% at the current hospital. So they took our advice. The contractors, my teammates, colleagues that I work with at this other facility, they said, you know what, we heeded your advice, and we dropped it down. So at least, we did have a little spoken word as a contractor, and we helped them. And even the CDSs that have been there a while says, no, this is too much. We're not gonna do quality data if we're sending all this stuff all the time. That's what I
agree.
Yeah, that's what I mean by trash in, trash out.
It's quality over quantity for sure in CDI.
Right,
Yeah,
right.
quality. Yeah.
Absolutely. It's all about quality. It's not quantity. It's all about quality data. That's the goal, because once you have quality data, reimbursement follows. I remember my first supervisor telling me that from the get-go at Cedars. Quality data, reimbursement follows, and it does.
And you know that your program is successful if you have the response rate high as well as the agreement rate high. So most of the time, those are the two benchmark that they are looking to see how successful your program is. Because if the doctor responds to your query, so you have an engagement with the doctor. So it means the doctor is working with you. Whether they agree or not, they're still working with you, they're responding to your rate. Agreement rate is that you are able to educate the doctor in a way of your query so they agree to whatever you're asking. So those are the two metrics or benchmark that they look whether it's successful or not. Some facilities don't even have a benchmark for how many queries you sent because like Anne-Marie said, you could send as many as as much as you want, but it's not quality, so it's useless because you're trying to reach the benchmark. So,
Right.
mhm,
And then your query rate too over time should go down, right? Because you're educating the docs. So are you going to maintain a query rate of 20 to 25% on a regular basis? You shouldn't, because the
No.
provider should be learning, right? They
Yeah.
should be learning with your education.
And
You
that's
know,
the whole purpose, educating them based on the queries. So they improve
That's
something.
right.
correct.
That's right.
Absolutely.
Yeah.
You know,
So yeah. So if you see a trend of the query rate going down, so you just have to the managers or the director, they look at it. Why is it going down? Because the doctor is learning, or is because the CDS are not sending queries? So they have to evaluate that. But it's mostly because the doctors are learning, so you don't have to query. They already documented it. So
right.
like for us before, it's like, oh my God, he already documented it. I have one query less for my benchmark. So it's just, and it's a learning process for the doctor. I believe that with our queries, the doctor also learned how to document. You don't have to really s- speak to them face to face to teach them. Sometimes it's more they're more responsive when it's just written, and they will get it.
Yeah. Right. And then speaking of that, I had a physician assistant call me. He was part of the trauma team. And he says, "Can you call me back, Emery? I have a question on the query you sent to me." And I was like, "Okay." Well, it was an abnormal BMI. The BMI was like 18.9, 19.1. And I was like, "All right, well, it's 19. It's right there. In this facility that I work for, they would query it. BMI 19. Okay." He said, "Okay." There was no nutrition note or anything available at that point, and the patient was getting discharged. So I called him and he goes, "Well, a normal BMI based on WHO regulations is the World Health Organization is 18 to 22. I said, "Okay." I said, "Well, we use the CDI pocket guide I use is this, this is my source that I use reference." And I gave him the information, and he said he wrote abnormal BMI. Then he put in the consult and additional notes that the CDI team uses Pinson and Tang CDI pocket guide, but WHO states that this is a normal BMI based on WHO organization or WHO requirements or references. So I was like, he put that in there. I was like, okay. So I put it, I disagree. I added it to the escalation process for my supervisor. And I said, "Hey, okay, just FYI, I said he uses different reference resource material than what I use from a CDI perspective." So it'd be interesting to see what they say to that PA, to say, okay, because there's other different reference materials out there, right? For the docs, best practice or this or that. So, like the WHO, World Health Organization, they have different references as well for BMI. So that's why it's just really interesting to see how things evolve over time, But that was just my little, he called me, the PA called me. I said, "Oh, I'll call him back, see what he wants, And that's what he was telling me. So Did he write it in the query, in the query template? Yeah, that's a progress note. But he confirmed that we use different references. So, okay. But he answered me, so it's interesting to see how things do develop because of different reference materials that are available for all the docs. That's the bottom line, compared to what we have in the CDI Pocket Guide with Pinson and Tang or Actus or whatever, AHIMA, Actus, whatever website. So just, keep an eye on that too, because there's a lot of different reference materials out there for docs today.
And also sometimes there is a confusion when measuring the agreement rate, because some facility will say it is agreed, the doctor agreed when they document what you want them to document, right? For example, you're asking for acute blood loss anemia, and the doctor did not document acute blood loss anemia, but they document, let's say, nutritional anemia. So they count that as not an agreement rate. It's like a disagreement rate. But some facility would count that as agreement because you're giving the doctor a choice. So
Right.
if you choose one of those that you give them a choice, they agreed to answer your query. So it's not a disagreement, it's an agreement, except that they don't know what you want them to write, right? They cannot read your mind. So so that is the dilemma sometimes with how they measure the agreement rate. And
Yeah.
I always what do you call this, justify my agreement rate with my director, because sometimes she will say, well, this is not an agreement, this is a disagreement or on your query. I said, no, I gave him a choice. So he said, none of the above. So he's agreeing to my query. He's not disagreeing because he doesn't know what I want him to write. So that is, you have to check out with your facility policy on what they
Right.
think is an agreement rate. But I would think that if they respond to your query, it is an agreement rate.
Right. And I think too, that's what in the current job that I work with this healthcare organization, if it's in one of the choices that they listed there, or even they put other, they're still giving you anemia specificity, just not what you wanted. Maybe it's not acute blood loss. It could be a chronic blood loss anemia, not acute. Okay. But you're still getting anemia specificity is the key. So they say, no, when you're getting specificity of a certain diagnosis that you're sending that query for, then it's going to be an agree. So, but it all boils back to going back to see what your facility policies are. That's the key. So like I said, everybody's different. So with the productivity metric, it's the number of initial reviews completed per CDS, and then number of subsequent reviews completed by the CDS, number of queries generated, and then the number of concurrent versus post-discharge queries. So they will take into account, so a patient is discharged and the coder asked me to send, a query for a path report. So as a CDS at the current facility I work for, coders cannot send queries, only the CDSs do. So we send all the post-discharge queries as well. Okay. There are some facilities that the coders can send their own queries post-discharge. Okay. But for right now, I send all the post-discharge queries for the current job I'm in, contract job. And they take that into account as well in the productivity metric with the queries. Okay. So your query types, like we were saying, there's financial impact queries, that's your MCC or your CC capture. And then, of course, your number of quality impact queries, your SOI, ROM data, core measures, and your hacks. And then any clinical validation queries that were sent. Now, your query response rate, they have some facilities will monitor the physician response and agreement rates based upon the CDS query that was generated. Okay. There are usually timelines specified within the organization's query policy, along with subsequent follow-up measures. So like Christy and I keep saying all morning long, it's like, look at your facility policies, see what they're saying. What is your query policy state? And also, just a little note, if physician response times are not listed in an official CDI query policy, be wary of using this type of CDI metric. I'm going to tell you, in prior position that I had with Henry Mayo, we didn't have response times within the metrics. The reason being, it was a small community hospital. We didn't have a lot of hospitalist teams. We had couple hospitalist teams that came in the door, but a lot of our docs were community docs. They had their own private practices and they saw patients in their hospital, in the hospital and in their office. So we never put a specific time frame. We would ask them, can you please complete it within 24 to 48 hours of receipt, right? Sometimes we get an answer. It was like the patient's discharged, and 2 weeks later we get an answer. And that's fine. And then we would update it. We wouldn't put a no response in unless it was absolutely necessary. And usually if it was greater than, I think, 45 days or something, we were discussing it. The supervisor, the management team, they were discussing it about, okay, when should we put a no response? So they were looking at specific time frame. They said it was 45 to 60 days or something. I think they were looking at that time. I don't remember if they did that or not. But however, in the current job that I'm in, they have physician response times listed within their metrics. And I'm going to tell you, these hospitalist teams that they have in there, they're responding within the same day. I put in the query in the morning, the afternoon, boom. That query response is in our work queue, completed. So just be wary, be aware that response times may be part of your facility's policies. The reason why, there's an incentive, okay? Because the hospitalist teams are working for the hospital, they're going to get a little incentive to complete those in a specific time frame. They get a little extra bonus money. All right.
Yeah, so in our facility where I used to work, it is included in the metrics for the doctors, like what is the turnaround time? They call it turnaround time. So it's 24 to 48 hours. So when I think every month they gather this information, and they present it to whoever is the physician, the PA. And
Physician
the PA
advisor. Yeah.
physician advisor, and the physician advisor will discuss this in a meeting, in their meeting with the doctors, and they will be, I think, talked to if it's like beyond 48 hours. So at least they would learn that it should be within 48 hours. So it incentivizes them to respond to your query, and most of them now are responding within 24 to 48 hours. So it's included in the metrics for the doctors.
Okay. All right. And of course, our query agreement rate. This metric ascertains that the correct query was sent for further diagnosis specificity. So once a query is generated for further specificity, the physician will either agree, disagree, or be unable to determine the correct, accurate response to the query request. So keep in mind, creation of accurate queries will lead to accurate capture of financial and/or quality impact diagnoses within the patient's medical record. And this is what Christy was mentioning too at her other facility she worked at before she retired, that, if there's a choice listed on that query, and the doctor does choose another choice or writes something in instead of unable to determine, then you know what, you got an agreement rate, but you got to look at what your policies are. it always go back to your organization's policies when it comes to query writing and agreement rates and so forth, and your productivity goals. So your quality query impacts, usually these are sent for SOI, your severity of illness, ROM, risk of mortality, your POA status, which is present on admission, potential hacks, as well as your core measure diagnoses. Now, I don't know, in HIM, we had a separate group department for core measures from CDI at one of the facilities I worked, and then they put them all together. So they just put all the group together for core measures and HIM. So the core measure nurses were trying to learn CDI, and the CDI nurses were trying to learn core measure diagnoses. So eventually they ended up separating them again because there were different rules, right? When it comes to your core measure diagnoses, those are the core measure team would look at the diagnosis after the patient's discharge. Something like the coders look at the final coding, right, for billing. So these can be considered like your educational queries, okay? Severity queries will increase your SOI and or ROM data indexes. But the severity queries, your SOI and ROM data, that helps third-party payers. That's your external quality organizations that look at patients who expired in the hospital. That's your mortality queries. Well, guess who does mortality reviews for the hospital? It's your quality management department, right? So they ask CDI, say, hey, can you look at these cases for me? We only have a SOI of 2 and an ROM of 3, and the patient died in the hospital. Is there any way we can look at getting additional information, diagnoses? Potentially, maybe we missed, and that's a possibility, right? We're human. And that if we can up that risk of mortality and SOI a little more, you really want your mortality reviews to be 4 out of 4. Extreme severity of illness and extreme risk of mortality. Likelihood they will die in the hospital because they are that critically ill. So your mortality queries definitely assist the third-party payers. That's why your quality organizations look at your mortality reviews, to say, okay, should this patient have died in the hospital? That's like a patient, 88-year-old lady comes in from the nursing home with a UTI. All of a sudden she's dead. Did she die from the UTI or did she get septic because of the UTI? Right? So that's what you want to look at. You want to make sure you capture all that information, all those diagnoses, to show that she was truly sick in the hospital setting. She just didn't pass away from a UTI. She passed away because she became septic. She developed septic shock because of the UTI. Okay? Okay, here's a quality impact query example. 56-year-old male admitted with altered mental status, AMS. Medical history includes multiple myeloma, or MM you'll see in the records. Not achieving remission. Pancytopenia secondary to multiple myeloma and history of TIA. The admitting physician documents AMS, unclear etiology. Workup reveals hypercalcemia, hyponatremia, and volume overload. Discharge summary notes hypercalcemia secondary to AMS due to back to baseline mental state, hyponatremia, and volume overload are all our diagnoses. So I just wanted to look. So what's our PDX for this patient? What bought the bed?
Multiple myeloma.
Multiple myeloma, right? Yeah. That bought the bed because they attributed the hypercalcemia to the multiple myeloma. And then we have, I think we have a secondary diagnosis. So we have them listed here, right? AMS, pancytopenia, hyponatremia, volume overload. And then our quality query opportunity, AMS, is an acute encephalopathy due to electrolyte imbalances, all right? So we sent a query to the doc, and the doc says, yeah, it's acute encephalopathy secondary to hypercalcemia due to the multiple myeloma. So we have an additional CC, and we increase the SOI by 1 with just getting other encephalopathy documented. Okay. So this is why it's important with other or unspecified encephalopathy, it's a CC. But if you get the type associated, the metabolic, toxic, and or both, it's an MCC capture. So this is just a quick example of just how to get that quality impact, because we don't have an MCC on the case, but we already have 2 CCs. Your pancytopenia and your hyponatremia are CC captures. So we did get another CC capture with the other encephalopathy diagnosis. Okay. So that's why quality impacts, you're not going to change anything. You're not going to change the MSDRG assignment. Now, say, for example, the doctor just said, no, it's acute metabolic encephalopathy secondary to hypercalcemia. So now we have that metabolic encephalopathy type, and that would change your DRG assignment from a CC capture with that MCC capture. Okay. So then you would increase your severity of illness, your risk of mortality, but also your financial impact, because we have multiple myeloma PDX under that MSDRG assignment with an MCC capture. Okay. And then your geometric mean length of stay goes up a little bit as well from a CC to an MCC capture, as well as your reimbursement, because your relative weight increases. All right.
Also, just follow up on the pancytopenia, since the patient has
Yeah.
multiple myeloma. Check out whether the patient had chemo either before admission or during the admission, because if it's if the doctor will document pancytopenia due to chemo, that's also an MCC. So that would also increase the SOI ROM, and it's an additional MCC, because the auditors also have a red flag if you only have one MCC. They will audit that because they want to take that MCC out. So at least if you have 2, I mean, you're safer. Like if they want to take out encephalopathy, which is the highest degree of denial right now, well, at least you still have the pancytopenia due to chemo. So
Right. Right. Yeah, it's always important. Pancytopenia is another one, like encephalopathy. It could be an MCC capture if it's related to chemotherapy. All right. Thank you. All right. Financial query impacts. Well, it's capturing an MCC or a CC within the record, and there's no secondary diagnoses. Okay. You want to change the MSDRG assignment with an MCC capture or CC capture, because there's no MCC or CC on the record. It's also, you're going to increase or decrease reimbursement for the hospital based upon the diagnosis being queried. So sometimes if you're validating a metabolic encephalopathy and they don't have it, they have dementia only, you're going to decrease that DRG assignment from an MCC to a CC. And that's okay. You're getting quality data. That's what you want, quality data. And then, of course, to assign the PDX accurately, since this will affect the DRG assignment, you want to make sure you capture that primary diagnosis. Like I said, when you're doing concurrent reviews, your working DRG will change because your primary diagnosis, your principal diagnosis will change as you're going along. If it's a sign and symptom code like syncope, well, definitive diagnosis, complete heart block. Right. Then they had a pacemaker. So it's a medical DRG that went to a surgical DRG because they had a permanent pacemaker placed. Okay. So it's always a moving target. That's the key. You got to remember that. Things always change after every review. Or they may stay the same if everything was documented right at the get-go. But I'll tell you that it's not all documented right as soon as they walk in the door. And then this is just a financial query impact example. 79-year-old female was found down in her one-story home. Friends contacted 911. When she got to the ER, the workup revealed CPK of 678. CT had positive for subdural hemorrhage. So the attending admitting MD documents traumatic subdural hemorrhage with loss of consciousness, status post-ground level fall, neurosurgery consulted, repeat CPK and CT head and AM. So query was sent to the provider, and the query response received by the MD, rhabdomyolysis secondary to mechanical fall. So we got a CT capture for this case. So the financial impact query opportunity elevated CPK. Is it rhabdomyolysis or is it traumatic ischemia of muscle? So, and this is where a lot of CDSs you go back and forth on, because if they had a fall, say they didn't have a fall the day they came in the hospital, but they had a fall the week before, and then they were getting worse with weakness, and then they got confused, and the week later after their fall, they came in with the rhabdomyolysis. Sometimes in the coders that I work with currently, they said no, because the fall, even though the patient had a fall a week ago, and the patient did have a subdural hematoma hemorrhage because of the fall prior to admission, that they coded the traumatic ischemia of muscle. Okay, so just be aware that, you know, there are certain things that we may not catch that the coders will, and it's okay. All right. We're never going to match up all the time. You know, like I said, we're all human. Things happen, and we don't see stuff afterwards, you know, especially when they're discharged.
Also, you have to look like we have a CC here, which is the rhabdomyolysis that the doctor respond to your query. So that is one CC, but just follow it up for additional CC. We could see that most of the time the patient have rhabdomyolysis, they have AKI. So check out what is the creatinine and follow it up. Is it increasing? Because that would also be another CC aside from the rhabdo. So at least you're safe with 2 CC. If it's audited, they can take 1, but still you have 1 CC left. Okay.
Right. Yeah. Good point. I don't like having just one MCC and one CC on cases because of all the denials that are out there today. All the insurance companies, even Medicare and Medicaid, they're all denying stuff. So you always want to have at least 2 or more MCC, CC captures for your records. Sometimes it's just hard. You only have 1, you know. And that's all, then fortunately, that's all you have. Okay. So when it comes to your clinical validation query impacts, so may be captured for financial. It's a PDX with an MCC or CC, or it's quality diagnoses. Okay, so it could be financial or quality impacts for clinical validation queries. Usually are generated for lack of clinical evidence to support the physician's documented diagnosis in a record. That's like the sepsis diagnosis that we went through about that with that coding example we gave, CDI coding review. Performed by the CDI physician advisor or champion within the organization. Usually it's a peer-to-peer. Now, what I tell, I will send a validation query initially to the provider. Sometimes if the provider says, you know, no, disagree, it's not, it still holds true for this diagnosis, even though the clinical evidence is not supported in the record. So, you know, you got a denial waiting to happen, especially if it's a sepsis diagnosis, encephalopathy, one of those red flag diagnoses we look at, ATN, you know, acute tubular necrosis with the kidneys. So you definitely want to escalate it. And usually with the disagrees that we have, on our current query escalation process, the supervisors will escalate it to the physician advisor or physician champion, whatever the provider's top title is, to have a discussion with that particular hospitalist. It's very informal. They just discuss it, you know, and go through everything, and the physician advisor will give them, you know, their feedback. You know, usually your physician advisors or champions, they've been around a while. They've been docs for a while, you know. You're not talking 3 or 4 years of of experience. You're talking, 10, 20 years experience as physicians. So, so it's always important to get your physician champions involved. And hopefully they are part of the escalation process at your facility. So this is a validation query example. A 56-year-old male admitted for syncopal episode during soccer practice. Admitting MD indicates syncope due to complete heart block, third degree AV block. Cardiology consult for possible pacemaker. Elevated troponins likely demand ischemia. That's what the cardiologist said. Cardiology consult documents SSS with intermittent third degree heart block and NSTEMI type 2 secondary to demand. So, do we have a demand ischemia or an NSTEMI type 2 is the question. So what do y'all think? You can look at your clinical indicators for type 2 MI. Even though we don't have all the information in the, example with the highest sensitivity troponins. Did the patient complain of chest pain or pressure? Were there EKG changes? What treatment did they give? Are they on aspirin, statins, and beta blockers? The patient was only DC'd with aspirin on this particular case. The patient really didn't complain of any chest pain or pressure. So a clinical validation was performed with the cardiologist by the CDI physician champion. Since the cardiologist is writing type 2 MI, does he have the clinical indicators present? Not really. So our physician champion did speak with the cardiologist directly, because even the attending provider spoke with the cardiologist, and the cardiologist says, no, he had a type 2 MI. But the clinical evidence in the record didn't support that based on the clinical indicators we review for a type 2 MI. So then he wrote that it was only demand ischemia related to AV block and not a true myocardial infarction. So when it comes to type 2 MIs, type 2 MI is never the principal diagnosis, as we know. That's per coding rules, right? It's always a secondary diagnosis because there's an underlying cause for that type 2 MI. But you want to make sure that you have the clinical indicators, the clinical evidence in the record. Did this patient complain of any chest pain or anything, palpitations, or, what did he have? What did he complain of? Pressure. You have to have some type of sign and symptom to really code that type 2 MI, like EKG changes. Yeah, he had third degree block because of the, that were the EKG changes. But did he really have a type 2 MI? Is it a myocardial infarction? Or maybe it was just myocardial injury because of the complete heart block. Okay. So these are other little things that you have to look at. And that's why I said the CDI pocket guides are so helpful, because it'll give you the clinical indicators you need in order to formulate a validation query like this. I think it's important that from a CDI standpoint, we do create an accurate evidence-based query for those providers, so that way they can give us an accurate diagnosis for the patients.
And I was gathering from other clinical documentation specialists that they really like the Pinson and Tang packet guide because it's simpler than the Actis one. It's more precise because the Actis has more explanation, while the Pinson and Tang has exactly what what do you call this? What the CDI really needs.
What you need to focus on. Yeah.
What you need to focus on. So.
Yeah, the Actis Pocket Guide is mainly it involves a lot of quality data they have in their Actis Pocket Guide. It's very thick. So if you've been a seasoned CDI for a while and you're doing mortality reviews or something like that, quality patient safety indicator reviews, that's a good one to have, from that standpoint. But as a CDS, when you're doing production all the time or you're getting into it, Pinson and Tang Pocket Guide is one of the better ones, because it'll walk you through the steps. It'll give you the information that you're looking for as a new CDS. And then fourth quarter 2017, page 12 indicates that code I21.A1 should be assigned in this situation without a query. So they said that we're going to code type 2 MI if a query wasn't sent. So that's why you always want to clarify, is it a true myocardial infarction? Or is it just demand ischemia and or myocardial injury? Okay. And there's new coding guidelines for myocardial injury that just came out. When did it come out, Christy? I think in 2020 or 2021.
Yeah.
Myocardial
2020,
injury.
yeah. Mhm.
Yeah. So there's other information available. They even wrote down the different types of MI now for providers now. So, you have type 1, type 2 is the biggest one. This is the most confusing, I think, for a lot of CDSs, because you really need to focus on what the clinical evidence is, those clinical indicators, to really capture that type 2 MI. All right. Okay, how you guys doing? Doing all right?
Yeah, thank
Yeah,
you.
we're good. I'm good.
Yeah. Did I fry your brains yet a little bit? Okay. All right. Well, let's go into this next one. Physician advisor champion role. I think this will help, explain a little more of who they are. Simply stated, they're a physician or healthcare provider who speaks with his or her peers on behalf of the team, CDI team. They work with us. Physician buy-in is key for all successful CDI programs. That's very important, because they explain the quality factors as it relates to diagnosis specificity. And they're also capturing the high quality documentation in all the hospitalized patients with follow-up in the office, and that yields them quality rewards. So that's the value-based purchasing. So it's not just for the providers getting an incentive, the hospital has incentives as well. And it also leads to quality data documentation within the office setting, so they get additional reimbursement, the providers. It's like, what's in it for me is what all the providers ask me when I used to go do education with them in their office. And I would tell them, this is what's for you. You can get additional reimbursement when you're looking at these different quality diagnoses. So you obtain feedback from physicians too, and that's where the PA will come back to the CDI team and say, hey, they have a couple questions, or add a couple suggestions. That's fine. We like suggestions, right? Because we're always trying to improve processes. And then they bring forth the value of the CDI programs to the physicians. So your PA or PC explains why CDI is so important within the hospital setting. So what do? They perform one-on-one reviews. They do clinical validation reviews mainly, okay? They promote high-quality data based upon clinical documentation. They explain the rationale, SOI and ROM data elements to the providers when they're doing a peer-to-peer. They promote diagnosis specificity for accurate SOI, ROM data. And we usually have scheduled regular meetings with the CDI team and our coding staff. So we usually have the PA or PC with during our meetings, our monthly meetings, when we had them at when I worked at Henry Mayo. So you know what? It's always helpful, because then you're getting feedback, right? It's like, you want to know how you're doing. You want feedback. Hey, how am I doing here on this job? Was there a missed opportunity? You want that information. You want to close the loop. And I think it's really important that even our PA, he would look at very complex cases, which may lead to a clinical validation query. We would ask our PA, it's like, hey, what do you think? Do you think we have enough evidence in the record to support the sepsis diagnosis for this patient? Because this patient died. she became, she went into septic shock. That wasn't what bought the bed for this patient, but do we have enough to, to really make sure we have enough clinical evidence in the record to support that septic shock diagnosis? Bless you. But also, educate the CDI and coding teams on pathophysiology relating to different healthcare topics. One of our docs, Dr. D, Zenny knows who I'm speaking of, he would come to our meetings and he would present a topic. He would discuss encephalopathy, the acute, even a chronic type. He would discuss AKI and ATN. He would discuss sepsis, all the different red flag diagnoses that are out there. He would bring the pathophysiology in and how, as a provider, healthcare provider, how he would document it and correlate everything accordingly. He would link stuff. And he did a lot of training with our hospitalist teams with me, because I was a hospitalist liaison and I did all the training with the hospitalist team. So we had 3 teams besides doing community docs. And he would come to the meetings that I had with the hospitalist teams because he would give them from a provider standpoint what he was looking for, what he would document. And it was really helpful because the hospitalist docs really enjoyed that. So why does the CDI program need a PC or PA? Well, it's buy-in. It's getting the other hospital physicians to work with us, right? We definitely want to make sure we have buy-in from all the providers. And you promote high-quality documentation for each patient that's in the hospital. And you encourage physicians to utilize the high-quality documentation elements within his or her office setting as well. So if you have community docs that you work with and they have an office that they have a private practice, you want to give them that information too, because guess what? It's additional quality incentive bonus for them. They get additional monies after a couple of years of trending certain diagnoses. So some of the challenges that could be associated with your physician advisor or champion, meeting with hospital physicians to perform clinical validation reviews. Sometimes it may take a week or 2 for the provider, your PA to get to that provider because maybe they're off schedule. They're off service for a week or 2 weeks, and then they come back 3rd week. They assist the CDI team members with arranging and scheduling the difficult physicians who may be tough to reach in the inpatient setting. So sometimes they help us by talking to the docs. They may call their office and say, or our one physician advisor went to the doctor's office after trying to reach him for 2 weeks. And he went to his office and said, hey, I need to talk to you, Harry, That could be difficult, It's hard to get that information relatively quickly, in a specific time frame. But also promoting a CDI program to all physicians as well as executive leadership team. Like I said, if you don't have the C-suite, the senior leadership, executive leadership team, whatever you want to call them, if they don't have buy-in with the CDI program may fail. Unfortunately, it will not be successful. So some of the values when you have a PA, of course, you get that buy-in with the physician peers. You have data collection. You're sorting documentation into SOI, ROM data points, but you also have physician scorecards associated with the high quality documentation. And I think that's great. Hospitals have scorecards, so do physicians, providers. I always go on, there's Health Grades is one, Leapfrog is another, and I'm always checking stuff out. I'm always looking at Health Grades to see, hey, is this doc a 4 or 5 star? Oh, no, he's only a 2-star. Why? What happened? And a lot of people will list that information in there. They'll tell you they went to the doctor's office and this is what they found, and they will never go back. So, healthgrades.com, leapfrog.com are all good ones to look at physician scorecards. Just looking up a provider. Even look up your own provider, see what he has. And there's a lot of learning and education sessions that go on between the PA and the CDI and coding teams. And then, of course, promote documentation cohesiveness from hospital to office charting. So, any questions about PA, PC? It's pretty straightforward. You definitely want to have a doc on your side in the CDI program because then they can do peer-to-peers. It's always helpful. All right.
Education.
Provider education. Challenges as a CDI specialist. What is it? Always physician buy-in from clinician to leadership level. Some docs don't bother me. I don't have time for this. Leave me alone. And that's what they'll tell you. And then you got to understand the what's in it for me. What is the doctor going to get out of it with your education of the provider? Educate on all diagnosis specificity relating to clinical indicators for high quality care data. It's all about the data, right? So when it comes to your high quality documentation elements, of course, you have legibility, and that's regulatory agencies, your CMS. TJC is the Joint Commission. It's not JACO anymore, it's TJC. Reliability, treatment performed without a diagnosis written. They gave IV normal saline for hyponatremia, but they didn't say hyponatremia. Is it precise? There's an unspecified diagnosis instead of diagnosis specificity, heart failure. So one example. Is it complete? There's an abnormal test result, clinically significant or not. You know, are they dehydrated or they have AKI going on? Based on that example. Is it consistent? Is there conflicting documentation? The attending documents elevated troponin due to demand ischemia. From sepsis, cardiology says it's a type 2 MI due to sepsis. Is it clear? Monitor for symptom codes. Chest pain. What's the underlying etiology, right? We don't want to sign in symptom code as a PDX, as your primary diagnosis. We want to make sure we get that definitive diagnosis of GERD for that patient. Is it timely? Are there shell notes not completed based upon hospital bylaws? Now you have to, again, look at your facility policy. Shell notes are when they put a progress note in for date of service 2/2, and it remains in draft mode for 3 days. They didn't even fill it in for that patient's hospital date 2/2 stay. And then they have it until 2/5. And it's still a shell note. 3 days of shell notes. They're not updating it. That's not taking care of that patient very well. And then the education, the why. When I tell the why, I tell the docs, assist the providers to paint an accurate inpatient picture from admission to discharge, improve SOI ROM data points, and better better return of investment or ROI with macro MIPS scores. These are part of the quality incentive programs that are out there for providers today. There are a whole list of stuff called HCCs, diagnoses. It's hierarchical condition categories that Medicare, it's mainly your Medicare, Medicaid recipients. They receive a quality bonus when they document that diagnosis once a year, like COPD is one of them. Even though they may not be an exacerbation, but they see them on a regular basis. They see them every 3 to 6 months or something based on that particular HCC requirement. And they write it in their notes. Okay. And this helps the providers in the inpatient setting as well as the outpatient setting, because you're promoting high quality care and consistent quality care from the hospital to outpatient. So a patient comes in, they have COPD or they got pulmonary fibrosis. They're on home oxygen. They're coming in the door with pneumonia. So you're treating that acute diagnosis of pneumonia while they're in the hospital, but you're also monitoring the pulmonary fibrosis, right? Or COPD during the stay. And those are HCCs that they capture. So you want to make sure those secondary diagnoses are listed within the medical record of the hospital. And then when they're discharged home, they're going to have a follow-up appointment with their provider, outpatient, after staying in the hospital. And then the doctor is going to capture those diagnoses within his claim form as well for during that hospital visit, post-hospital visit. So some of the quality incentive programs, the MACRA, MIPS, and APMs, you can see they're all different types. MACRA is mainly to control physician spending for Medicare recipients, right? There are 2 payment program options available. I didn't list them down here though. MIPS is your merit-based incentive payment system. And this is a quality program that combines physician quality reporting services, or your PQRS, the value-based purchasing program, and electronic health record incentives all in one. So these are some of the quality incentive programs that the doctors will see on their side outside of the hospital. APMs are the alternative payment models. There are several types that are part of this model. HMO companies are mainly using this model, like Kaiser and HealthNet, the different HMO companies out there. Now, you know, there's so many more. And then your Affordable Care Organization, or your ACOs, is another type that came through back in 2005 or 6 or something. Another type of payment model, and this is where it incorporates the hospitals, physicians, and other healthcare providers to coordinate care for your Medicare recipients. Okay, so there's definitely quality incentive programs out there for the provider. So when I ever tell them, they always ask me, well, what's in it for me? I was like, well, let me show you. I grab a physician scorecard, their physician scorecard. I grab the HCC's information, and I tell them, see, these patients have all this diagnosis. So diagnosis specificity is key. And treatment, focus on your specific conditions. Is it an acute or chronic condition? It's based on all your clinical indicators, your clinical evidence in the record for each diagnosis that's listed. But you also want to minimize abbreviations, right? And Joint Commission Standard MOI-.4, to prevent misunderstandings and potential risks to patient safety, MOI.4 requires hospitals to establish lists for approved and do not use abbreviations, and monitor for appropriate abbreviation use. Now, do you think a lot of hospitals have approved abbreviation lists or not approved abbreviation lists? What do you think? No, I don't think so either. If you do have a facility where they have it available, good for you. That's great. Most hospitals don't. The larger hospitals, you know, your university, medical center hospitals, things like that, they won't have time to do all that. What we tell the docs, if they're writing an abbreviation and they want to write it the rest of within the progress notes and or discharge summary, if it's the attending provider, we ask them to spell it out at least once or twice in the record. So they spell it out once when they use it, and then we ask them to spell it out again in the discharge summary. Okay. Depends on what, like I said, it goes back to your facility policies too. Also, if unknown or uncertain etiology, document it until workup completed. You know, we tell the docs, well, what are you documenting on the syncope? Is it unsure if it's a cardiac or neurological etiology? And they document it. I just clarify it. If they don't know what the cause was of that syncope, well, you're going to have a sign and symptom code for syncope, right? That's what you're going to be stuck with in the final coding and final billing. You can't do anything about it. They never found any cause for the syncope. Okay. But you always try to link the symptom to the underlying etiology. And then provide data to physicians based upon diagnosis specificity with increase or decrease in SOI, ROM data points. All of these items provide high quality care for your patients in the long run. You know, they have to go by best practice, right? Their core measures, sepsis criteria now. They have policies in place for sepsis when you're treating sepsis. You know, that's a core measure for the hospitals. You want to make sure you capture all that. You go according to what their policy is. That's Medicare. And Medicare is core measures, diagnoses. So just FYI, it's not other commercial payers, but other commercial payers may incorporate that information within their policies as well. Okay, like your Blue Cross or Aetna or United Healthcare. So when it comes to quality documentation, it counts because look everything that it affects. It affects your medical necessity, length of stay. That's where your case management or your care coordination department's involved. Reimbursement is coding. Business office for the hospital. Severity of illness, risk of mortality. Our RAC audits and compliance, right? If you get a RAC audit, they want these records for a specific DRG, then they're looking to take back money. That's post-discharge. They want to change the DRGs around. So you definitely want to keep an eye on, that's why you want quality documentation, diagnosis specificity. Your POA status, present on admission, is always important. And profiling hospital and physicians is always important as well. Now, this is where I say, what's in it for me answer for the physician scorecards. It's all data. They love data. Providers love data, and they do like a little bit of competition among their peers. I'll tell you that. So you want to provide several topics within a specific time frame, usually 6 months or a year, and you show them what their MCC CC capture rate is, what the SOI ROM capture is for their patients, unspecified code usage, and usually an average CMI or case mix index. Now, you can do separate physician scorecards, and then you can do a group scorecard for the hospitalist team, say. So you look at different hospitalist teams, and then you give them, oh, this other hospitalist team had this CMI of 2.1, but your hospitalist team only had 1.9. What happened? Okay. So a little friendly competition goes a long way with hospitalist teams, that's for sure. And then you want to educate the physician what documentation was done well and what documentation does need a little improvement. You give them some H&P examples, some progress note examples, even discharge summary examples. I mean, I created a presentation for the docs, and I would specifically look at their documentation and say, kudos to you. I gave them a couple gold stars on their little, on their documentation that really was definitely right on the money for high quality documentation. Diagnosis specificity.
Yeah,
This is just
like,
some of the,
then I
Go
just
ahead.
add, like, for example, the big facilities or big corporations like Dignity Health or Kaiser or I think Adventist Health. Each facility have their own data, and then they compare it with the other facility within the organization, and they'll say, okay, why is Northern California did better than us? So they will dig on that, and then also they do one-on-one with the doctors, and at Adventist at Memorial, the PA will talk to the doctor and tell, okay, you documented this, you answered the query, look how much, they talk about money, how much you did um, added to the hospital financial status. Also, since you did that, see what happened to your, let's say, your rating. How are you being rated? So in a way, the physician advisor is really important because it explained to the doctor what they needed to improve and what they did that did great. So at least it boosts their morale. So whenever when I was at Memorial before, whenever the physician is having a scheduled peer-to-peer, I'm always there. I provide them with the CDI metrics so they could see how their documentation helped the hospital at the same time help them.
Right. Yeah. Very true. Very true. Thank you, Christy. Okay. And this is just an example from healthgrades.com. There's a couple of the cardiologists I worked with. Of course, most of them got 5 stars, which is good. You want to, even an anesthesiologist, you're going to have to go through surgery. You want to make sure that your lung and heart doc is on top of his game. Okay. How you all doing? You doing okay? We're
Yes.
almost done.
Yes.
Yep.
All right. This is the last section. So we'll go through this. We'll take a quick 5-minute break. And then you all can fill out the evaluation for us, the evaluation form, and we'll go through the post-test together. Okay?
All right. Thank you.
Okay.
All right.
Let me know if you
Coding
didn't
is-
receive the email.
Yeah.
Yeah, I
let
got it.
Christina. Okay. Coding and CDI, teamwork. Teamwork, teamwork, teamwork. I always say that. I can't stress that enough. So why HIM and CDI? Communication is key. What's our one goal? We want accurate data. That's the key. We want accurate data for patient care and safety, for quality measures that are out there, and appropriate reimbursement. Accurate data. Telling the story of a patient's admission through discharge from provider documentation. Specific documentation leads to high quality care, true severity and mortality data points and scores, and appropriate reimbursement. Because once you have that high quality diagnosis specificity documented within the record, everything follows quality and reimbursement. Coded data is also sent to external auditing agencies like your Medicare Quality Initiatives, your Agency of Healthcare Research and Quality, healthgrades.com. So there's a lot of quality companies out there. So that's why whenever we were talking about final diagnoses on the coding summary that the coders had to do, and they're like, well, do we have enough evidence to support that diagnosis of metabolic encephalopathy? I said, well, you know what, let's ask. Let's pose a post-discharge query to the doc and see what else he could add in there. And he goes, no, it's more likely a progressive dementia with behavioral disturbance. So, you want to make sure you capture that accurately. The accurate diagnoses are key because these diagnoses, these claim forms with all these other diagnoses on there and procedure codes, they're all sent to all these other auditing agencies. So, it just doesn't stop after the patient is discharged from the hospital. Patient safety. You want to minimize adverse offense, right? In the hospital, especially you don't want somebody dying in the hospital unless they're really critically ill, that, they're at a severity of 4 and a mortality of 4, that they are going to likely die in the hospital based on what brought them in the door. So there's also a survey they asked patients their perspective on the quality of care they received. That's known as the HCAHPS, the Hospital Consumer Assessment of Healthcare Providers and Systems. So the hospitals send out this HCAHPS to the patients that were in the hospital, right? And it incorporates questions like communication with the nurses and doctors. Were they receptive to you? Or did they respond to the hospital staff? Were they responsive to the patient? Did they have an issue with them? They're going to write that on that survey, patients. Was the room clean? Was it a quiet environment? Did they receive medication information from the doctors and the nurses? The discharge summary, was it explained to them in their entirety what they needed to do? Or were there follow-up appointments made for them by case management? That's listed in the discharge summary when the nurses are going through that stuff. Discharge instructions, excuse me. Okay. This all plays a role. You do want a high HCAHP level. You want at least an 80%, 85% or higher. When you start getting HCAHP scores about 60 or 70, that's telling me that, the hospital is not doing a really good job with maintaining patient safety in the hospital for those patients. So, and these are all governed, patient safety is governed by CMS, AHRQ, and the HQA, which is the Hospital Quality Alliance. That's another quality organization externally that's out there that collects all this data. So when you're submitting your HCAHP scores to the governing agencies, hospitals may receive incentives based on the quality of care they provided to their patients, which is all part of the value-based purchasing program for hospitals, or they may not receive any incentive whatsoever if they got a low HCAHP score. Okay. So there are 28 hospital quality measures that the hospital needs to review and abide by. Some of them are procedures associated with inpatient mortality. Did they die in the hospital based on the surgery that was performed? Is there a condition-specific mortality that they had? You know, did they die of septic shock? Were they that sick? Overuse, misuse, or underuse of procedures performed? Are they doing imaging or testing that's not needed for that patient based on the diagnoses they were admitted with? Now, your mortality data centers focus around the inpatient quality indicator, also known as IQI 90. This is also known as PSI 90. And PSI 90 is Patient Safety Indicator 90. Now, from a CDI perspective, we want to keep an eye on these. This is from patient safety. We want to incorporate. So as you can see, the PCI 90s, the PCI 3, 6, 8, 9, 10, 11, etc. Some of these are also listed on the hospital acquired conditions or your HACs. So that's why we take a look at all this stuff. If patients develop like PSI 12, they develop a PE or DVT during surgery. Okay. Post-op sepsis rate. Did they get septic after the surgery? Did the surgery cause the patient to get septic? That's what you got to look at. Okay. This is where your quality department is also looking at when the patient is discharged. They look at all this stuff.
Sometimes they ask also the CDS to report during our review whether there is a possible PSI on the patient's case. And you also have to remember not because it's present, it is also already a PSI. There are some exclusions, right? So like for example, the postoperative acute kidney injury rate, if it was the patient had AKI after surgery, but no dialysis is needed, then it's not a PSI. So there's some exclusions there. Or if the patient has a respiratory failure post-operatively, but the patient has a diagnosis of COPD prior to admission. So that's not a PSI. So those are the things, they have it on a website. What are the exclusions for the PSI? It's kind of cumbersome, but I just refer it to my manager and she will decide whether to report it to the quality people.
Yeah. And then the quality, your quality department, they'll review those cases as well. That's like your mortality reviews. When somebody dies in the hospital, quality department will review all those to say, okay, you know, no, we didn't cause harm to that patient to have her, he or she pass away. You know, unfortunately, it was all the diagnosis, the conditions that brought them in the hospital that they ended up succumbing to. Okay, and last but not least, reimbursement, right? So coding instructions and conventions in ICD-10-CM and ICD-10-PCS take precedence over the official coding guidelines, which take precedence over coding clinic advice. So coding clinic is like your bottom of the pile when you're looking at information, okay? But your PCS, your code books take precedence. And then your official coding guidelines are second, and then your coding clinic advice is third. The primary reason why the patient was admitted to the hospital drives our MSDRG, right? That's what we said. Circumstances of admission, or what I always call what bought the bed. Your secondary diagnosis may be coded based upon the utilization of resources, right? And we discussed this. Your clinical evaluation, therapeutic treatment, diagnostic procedures. They ended up staying longer in the hospital. Maybe they developed another diagnosis that wasn't expected, and they ended up getting more nursing care, or they had to go to a higher level of care from telemetry to ICU or something, okay? So they're staying longer in the hospital. And then you want greater specificity of all diagnoses, acute on chronic, your acuity, your severity, higher reimbursement, which also increases your SOI and ROM data points, okay? The more specific diagnosis you have documented it within that record, the higher quality of care that patient receives during the hospital stay, and the hospital will receive the reimbursement accordingly. Okay. And if a condition, one example, if a condition was listed as a history of within the documentation and patient no longer receiving anticoagulation treatment, how would you code this condition? Would you code acute popliteal DVT? Zenny or Carmen, you got a guess?
Hmm.
So if they're not receiving treatment,
Yeah, if they're not receiving treatment, then we wouldn't code it. But if it's
then you
something
wouldn't
that
code it,
we're-
right?
Yeah,
However, you would send a query to clarify it, correct?
that is
Yeah.
correct.
Yeah. So you would definitely want to clarify diagnoses such as these when they're acute, they're listed acute. There's no treatment performed. There's no imaging done to suggest that this patient has an acute DVT. Okay. These are some of the quality diagnoses that you want to look at from a CDI standpoint. So in summary, understand the who of clinical documentation programs, apply the general coding guidelines as set forth by the 4 cooperating parties, promote physician buy-in through education, you collaborate with multidisciplinary teams within the hospital setting, educate physicians relating to diagnosis specificity, severity of illness, and risk of mortality data points, as well as promote continuous communication and education between the CDI team and the coding professionals.
Thank you for watching the webinar. Please click the link in the description to obtain CU certificate.